Good morning. On behalf of Taipei Medical University, first, I would like to welcome today's speaker from all over the world. Good morning, good afternoon, and good evening, everyone. As COVID-19 pandemic has been raised again in Taiwan recently, our university followed the government's preventive guideline and particular caution, hoping to continue all the activity as usual and in consideration of people's health. Therefore, I'm very happy to participate in today's ingenious forum held by the College of Public Health, and gathered together with 15 speakers from 7 countries and the audience in a safe way of continuous exchange. Our university drives school affairs with the vision of becoming a world-class medical university. Thus, this type of international exchange are particularly important for us. Thank you to all the international speakers who come to participate today despite the time difference. And we are also committed to cultivating future biomedical experts with social influence to serve the society. Therefore, we also wish to extend our gratitude to the speakers from National Health Research Institute, Academic Seneca, Taiwan Center of Disease Control, who share their real practice and serve as role models. In addition to being a school, Taipei Medical University also operates 4 affiliate hospitals, a cancer center, and a neuroscience center. I'm also very happy to see our achievement in teaching, research, and public health and medical practice here, and hope to make the purpose of serving the society through and share this forum. Nowadays, the frequent global transportation interaction has made the cross-border import and export of disease even easier. Discussion on the infectious disease and chronic disease under the pandemic require mutual cooperation and experience sharing throughout the different countries. This has made strengthening a global partnership one of the keys against epidemic and public health. Not only the speakers of today's forum come from different countries, the students participate, these and audience are also from more than 10 countries. All of the students are the seeds of the global public health and the future. I sincerely hope this International Public Health Summit can generate new sparks and influence, and wish you all a very fruitful days. Thanks.
Research in psychiatric and behavior medicine, and also currently also the editor-in-chief of Asia Pacific Journal of Public Health. Today, Dr. Liu is going to share with us stage.
Not violence during the COVID pandemic. And reports from China, UK, and US, and other countries suggest an increase in domestic violence since the COVID-19 outbreak. And of course, in one province of Qingdao, that people, police are experiencing more domestic violence as compared to the previous year. Now, this is reported in China, where COVID violence in the Hubei province. And of course, if you were to look at the health impact of violence itself, particularly the intimate partner violence of women and children, they are very significant in terms of injuries and serious physical, mental, sexual, and reproductive health problems, including STI, HIV, and of course, unplanned pregnancy. Now, quickly move on. These are the health impact, and I believe earlier in opening remarks by Professor Chu, he has also briefly actually cited this as well. The health impact, women exposed to intimate partner violence, as far as mental health is concerned, is twice as likely to experience depression, almost twice as likely, to have alcohol use disorder, and as far as sexual and reproductive health is concerned, 60% are more likely to have a low birth weight baby, and of course, 1.5 times more likely to acquire HIV, and 1.5 times more likely to contract STI. And death, 42% of women experience physical or sexual abuse at the hands of partner who experience injury. And globally itself, 38% of all murders of women globally are reported as being committed by their intimate partners. Now, let us look at the increase in domestic violence, especially during this COVID-19.
For Dr. Liu Huayun, but you need to wait until the Q&A section, okay? And we have an entire session for the discussion. Right now, let's move to the second for this section. And for this speech, we have two speakers, Dr. Chen Yihua and Dr. Pyongyang Kim. Let me introduce Dr. Yihua Chen first. Dr. Chen is the dean in the college, Taipei Medical University College of Public Health, and also a professor in the School of Public Health. And Dr. Chen, his professional academic achievement, he already published more than 100 papers related to mental health. And as a public health leader, he also showed the enthusiasm to serve on many national advisory committees in the Ministry of Health and Welfare. Those advisory committees include tobacco hazard prevention and healthcare fund delivery group, suicide prevention, as well as sanitary medical service and social welfare policy promotion, and mental health improvement. And let me also introduce Dr. Pyongyang Kim, the other speaker for this topic at this moment. And Dr. Pyongyang Kim is an associate professor in the psychology department of Denver University in the United States. And he also a director of the Family and Child Neuroscience Lab, and also a co-director of the Brain, Artificial Intelligence, and Child Centers. Dr. Kim's research focuses on the role of early experience on brain development. For example, in her current NIH project, okay, with more than $1 million US dollars. In this project, he investigated how the experience of poverty and exposure to cannabis during pregnancy influence the infant brain development. Dr. King also published more than 80 papers related to early brain development and health. Okay, today Dr. Yiha Chen and Dr. Pio Yang King is going to speak to maternal and child health under COVID-19 stress in Taipei.
Early pregnancy to 1 month postpartum for women in the pre-COVID and post-COVID period, together with its association with birth outcomes in Taiwan. And in the second section, Dr. King will present the results from Denver. All right, so why is that maternal mental health important during COVID-19? We can see that pregnant postpartum women are vulnerable to emotional disturbances, and the concerns may be about the well-being of the unborn child, together with unintended consequences of preventive measures, such as quarantine, physical distancing, home isolation, and probably inability to obtain expected level of support and care prenatally and also in the postpartum years. So we'll focus our examinations from January 2020, and this is the first case in Taiwan, up to the January 2022 this year. And you can see that we have an outbreak this May in Taiwan. All right, so we attempt to look at the change of prenatal health from early pregnancy to postpartum years. And we define our pre-COVID to start from January 2018 to January 2020. And also the post-COVID period started from January 2020, which is the first case in Taiwan. So you may observe the result. The blue line here with a pre-COVID woman, and the orange line is post-COVID woman. And interestingly and surprisingly, you can see that the pre-COVID woman actually expressed higher level of depression from early pregnancy to 1 month postpartum, all the way along compared to the post-COVID woman. And similar conditions can be observed for anxiety scores. Again, we can see the pre-COVID women express higher level of anxiety scores compared to the post-COVID woman. Now we are thinking about the reasons. Maybe the COVID conditions has been well managed in Taiwan during this period of time. And also we think that maybe resilience may play a role in it. So we'll do more research on that. And what about the positive mental health? We can see its positive effect. And then in this domain, for post-pre-COVID women, you can see the trends are pretty similar, consistent. And we further look at the effects of prenatal mental health on birth outcomes. So these figures for pre-COVID period of time, and using G for analysis. And you can see that no significant findings were observed here. However, in the post-COVID period, we can see the eudaimonic well-being. This is a sense of meaningful life with the self-actualization, and also the positive effect. Both are positive mental health. These are associated with decreased risk of preterm birth. Okay, and then for negative mental health, including negative affect and depression, we can see that they are associated with increased risk of preterm birth and low birth weight.
Anxiety as well. So again, the red line is post-COVID group, and blue is pre-COVID group. That we see that there was elevated depressive and anxiety mood. Unfortunately, the mothers who were experiencing COVID pandemic. So we think in the U.S. this reflects that what was happening in the U.S. that there were quite high levels of perceived risk and actual risk of getting COVID. A lot of women were very concerned, and there were a lot of social changes as well, along with the pandemic. So yes, this could be potentially very concerning. And as you just heard from Dr. Chen, that because we found completely opposite pattern between two countries, right? In Taiwan, there was actually lower mood symptoms in post-COVID group in Taiwan, and in the US, it was higher negative mood in the post-COVID group. So we're investigating those differences and what might be driving. So for the remaining time, that what I would like to do is to kind of share a little bit of my research program. We're also very interested in negative mood or stress, pregnant parent experience, potentially because those stress might be transmitted to the second generation, like the fetus. So some of you might be very familiar with this, but during pregnancy, some of the mothers experience depression, stress, and some of the other difficulties like partner violence, the first speaker highlighted. So those experiences can actually increase the glucocorticoid levels or stress hormone levels in woman's body, which can be actually transmitted to fetus during pregnancy. And unfortunately, those that have the cascade impact on the development of the second generation, that in turn increases the risks for mental health and physical health. So we were very interested in what might be very early neuromarkers of this intergenerational transmission of stress. And in our lab, the primary research method is neuroimaging, particularly fMRI. And in our research program, the protocol is that we do neuroimaging with mothers and as well as the newborn as soon as the baby is born. So we were very interested in whether the stress the mothers experience during the pregnancy might be actually related to the brain outcomes of the mothers as well as the newborn. Particularly, we were very interested in how similar the mother's brain might look like with newborns. And the reason why we were very interested in that, for the studies with much older children or adolescents, if the mothers actually had, for example, depression, some higher the kind of mental risks, there were actually greater similarities between the mothers and the children in terms of their brain structure or their function compared to the mother-child pair when the mothers didn't have those risk factors. And those might be related to like some of the like genetic and environmental risk factors that might be actually related to depression or those other factors. So we were very interested in, could be those kind of environmental pressures or risk might be related to the similarities, the degree of the similarities we might see between the mother and the newborn just being born, and could be potentially the intergenerational transmission of the neuro risk markers. So the way that we did this study is that the mother was being imaged in terms of her brain, but also the infant's brain was being imaged while the infant was naturally sleeping. So as you can see here in the picture on the left, the infant is actually inside the scanner sleeping, and the research assistant is there to kind of monitoring the infant's condition. And on the right, about 4 years ago, actually, I had my own son, so we did the very similar protocol. So that's the image of the brain and the image of my son's brain. So just to kind of show you the images, that's how the study was being done. So in this study that we had 30 dialogues between the birthing parent and infants. And then the birthing parents, based on the US, the demographics, it reflected the Denver demographics. And the birthing parents' educational levels were between 11 years to 20 years. So I would like to highlight that actually we did not have very low number of the years of education. So please count that into the interpretation of the result. So in this analysis, first thing we did was that actually just look at the similarities between the mother's brain function and the baby's brain function. And these regions that are highlighted in red were the regions that there were more similarities between the mother and the infant. And not too surprisingly, what we found was that in infants, a relatively more mature brain network like sensory motor network, visual network, and auditory network. So those networks actually already at birth have a relatively mature functional connectivities. So those networks showing more similarities between the mother and her infants. And the next step was that we wanted to look at the amount of the similarities between the mother and infant and the mother's educational level as an indicator of potential socioeconomic risk. And what we found was that the lowered maternal education levels were related to actually more similarities in the brain between the mothers and infants. So that is the graph here across the whole brain. And we look at the specific network related to emotion regulation, attachment, and some other brain network. We saw very similar pattern. So this might be somewhat counterintuitive, but as I mentioned earlier, that it seems like those environmental pressure can actually sometimes send a signal to the infant's brain, in this case potentially be fetal brain, that the brain might need to mature faster. So some other studies with infants who are exposed to high level of environmental risk, like maternal deprivations or maternal depression and anxiety, people actually found those infants whose mother was depressed or anxiety showing actually more mature brain profile. That it's kind of a little bit similar ideas that how some of those children from the family at high stress might reach puberty earlier. So it is kind of potentially evolutionary pressure for those babies to mature early. However, we're very concerned if that is the case, because for the brain to reach the full potential, we would love to see that the brain actually has more slower developmental trajectories, especially during those early years. So those kind of precocious development can actually make those windows to be a lot narrower and might actually increase the challenges to reaching their full potential. So that is the last slide. And thank you so much again for giving me this opportunity to share some of my research with Dr. Chen as well. Thank you.
And thank you for Dr. Chen and Dr. Kim. Okay, I think the result of functional result related to the functional connectivity is quite interesting. Okay, modified by the mother's education. Okay, if we have more questions, then we can raise the question in Q&A session. Right now, let's move to the third speech from Dr. He Jianhui. Dr. He Jianhui right now is a professor in the Jackie Club School of Public Health and Primary Care. Her research focuses on developing exposure assessment techniques and modifying chemical toxicology characterization methods to quantify the personal exposure and health impact of air pollution. Okay, his research tries to bridge the gap from air pollution resources to health. And wow, Dr. He very often publish his paper in high-tech journal very often, such as Nature and journals of hazardous materials. And recently, he also got some highly prestigious awards from the Chinese Association of Aerosol Science and Technology. And today, Dr. He Jianhui is going to speak to health effect of ozone and his precursors in Taipei, not Hong Kong, okay? I'm sure in Taipei. Let's welcome to Dr. He Jianhui to the stage. Dr. He, please. Dr. He?
Yes, I'm here. Hello, can you hear my voice?
Okay, your voice is low.
I would like to share my PPT, so maybe stop sharing in the previous slide. Hello, I cannot share because it's still. Okay, thank you. Okay, thank you, Chairman. Okay, good morning. First of all, I would like to thank Taipei Medical University for their invitation for this public health summit. I'm Kim Wai Ho from Jockey Club School of Public Health and Primary Care, the Chinese University of Hong Kong. And today, I would like to share the topic about the health effects of ozone and its precursor using Taiwan as an example. In the past 2 years, due to the outbreak of COVID-19 pandemics, actually we spend most of the time at home for work or study. Some cities were under the strict lockdown during the outbreak, and the human activity has been greatly reduced. There are lots of study to explore. You can so see here a lot of study to explore the impact of the air pollution and health after city lockdown. And most of the studies show that the emission of nitrogen dioxide and even PM2.5 reduced significantly. When we compare the result in 2019, the air quality has been greatly improved actually, but the level of ozone still remains. When the pandemic is slowing down in 2021, we can see a lot of news about the emergency of the new the hazard weathers. Sometimes it's due to man-made reasons, sometimes it's due to the meteorological conditions. And this is not only happening in Taiwan, but also in Hong Kong and many other cities. But actually, the Taiwan government used a lot of ways to reduce the emission in the past few years. You can see that in north, central, and south part of Taiwan, PM2.5 dropped significantly, and sometimes more than 70%. However, the ozone concentration has an increasing trend. You can see in the northern part of Taiwan, is as high as a 14% increase. We know that ozone is a secondary pollutant produced by some precursors during the photochemical reaction. The precursors are nitrogen dioxide, or what we call the NOx, or some we call volatile organic compound, VOC, which emit from different natural and anthropogenic sources. So in order to control the ozone formation, we need to control the emission from the precursor at the same time. So as we observe the increasing trend in the ozone in Taipei, in Taiwan, or even in Hong Kong, it is important to determine the health effects of ozone and their precursors. Ozone is a very strong reactive oxidant with both inflammatory effects and oxidative damage to the respiratory system. Here shows some syndromes when we inhale the excess ozone, like difficulty breathing deeply, shortness of breath, sore throat, wheezing, coughing, etc. In some periods, study positive association of short-term ozone exposure with daily respiratory mortality and mobility have been reported. Moreover, those studies are mainly focused on the ozone effect on COPD and asthma. However, there's a limited study on the effect of ozone on like pneumonia and other health effects, or even a long-term ozone effect is not reported or is quite limited. Therefore, I would like to use Taiwan as an example to study the health effects of ozone and its precursors. Here are the three studies I would like to discuss today. The first study is to determine the association of ambient ozone with pneumonia hospital admission in Hong Kong and Taipei. And Hong Kong and Taipei have similar primate, but different population density, smoking rate, and different healthcare system. So I would like to use these two cities to analyze the relationship between the atmospheric ozone level and pneumonia. The study period in Taipei is from 2010 and 2017. Exposure data, including the ozone, PM 2.5, and nitrogen dioxide, we collect from 5 air quality monitoring stations, which are under Taiwan air quality. In general, this is a time series study and analyzed with generalized additive regression model integrated with a distributed lag model to determine the lag effect. Meteorological parameters like temperature, relative humidity were collected and used to adjust the model, and hospital admission data were collected from National Health Insurance Research Database in Taiwan. The study period in Hong Kong is from 2010 and 2016 is similar to Taipei. And exposure data, including ozone, PM 2.5, and nitrogen dioxide, is the same. But the data is collected from 10 general monitoring stations. We apply the same methodology for the data analysis, but we use emergency hospital admission data, which is collected from Hospital Authority in Hong Kong. Here, the major finding, we can observe there's no harvesting effect of ozone in elderly population in both cities, which means there are significant health impacts of short-term exposure of this population. And sensitivity analysis with different matrices of ozone confirm the consistent and robust association with pneumonia hospitalization in Hong Kong and Taipei, especially in the elderly population. The estimated effect magnitude were greater in Hong Kong than those in Taipei. The main reason may lie in the emergency hospital admission data were used in Hong Kong, but a general all hospital admission data were used in Taipei, in which we could not identify the emergency sources in Taipei. Seasonal analysis showed that the effect estimate of ozone matrix on total pneumonia hospitalization were greater in magnitude in cool season than in the warm season in both cities. The stronger association observed in cool season was consistent with the finding from southern China. It may result from the reduced air conditioning usage, more natural ventilation, more outdoor activity, therefore more ambient exposure in the cool seasons. And the results is already published in Environmental International. The second study is a cross-sectional study about the air pollution exposure and sleep disorder. In this study, we applied a newly developed land use regression model to estimate the personal exposure, mainly PM 2.5 and nitrogen dioxide, according to their home address. The detailed model and also the validation result was already published in atmospheric chemistry and physics. So if you're interested to this land use regression model, you can take a look at this paper. For this sleep disorder assessment was performed by the physicians in Sleep Center of Taipei Medical University Hospital with ultrasound tomographies. Here shows some parameters we measured in this study, including the total sleep time, sleep efficiency, wake after sleep onset, the AHI, arousal index, and the blood oxygen saturation. And this study, finally, there's a 4,600 participants with sleep problem were included in this cross-sectional study. A generalized linear regression model was used to estimate the absolute change of total sleep time, sleep efficiency, and the percentage change of wake after sleep onset associated with the per interquartile range increasement of pollution exposure. And then we also use a multi-nominal logistic regression model to estimate the relative risk ratio OSA with or without no arousal threshold compared with those non-OSA patients. So in our analysis, we divided the subjects into 3 different groups. The first group was non-OSA, the non-obstructive sleep apnea, and the second group was OSA with no arousal threshold, and the third group was OSA without no arousal threshold. So the criteria of the no arousal threshold was shown on the upper left corner. You can see here. We can observe that the OSA without no arousal threshold tend to have more serious OSA characterized by the higher HI, lower oxygen saturation, which is consistent with the clinical observation and some studies. But in contrast, the low arousal threshold OSA patient had the lowest sleep time, sleep efficiency, longer wake after sleep onset time, and a relative higher arousal index. Here are the analytical results. We find the association between the pollution exposure and the sleep measures in the single pollutant. In the single pollutant model, an interquartile range increasement of PM2.5 over the past 2 years decreased 3.5 minutes of sleep time and 1% of sleep efficiency. And then an interquartile increasement of NO2 increasement average over the past years decreased 3.6 minutes of sleep time, 1% sleep efficiency, and 3.6% of wake after sleep onset. Here we show the result when we compare with non-OSA patients. The excess risk of no arousal threshold OSA was 70% per interquartile range increasement of NO2 at lag 0 to 6 days, and 30% per interquartile increasement of NO2 average over the past 1 year. Such effect estimate changed slightly to 22% and 30% respectively after we adjust with PM2.5. But we did not find significant finding association of NO2 with the increased relative risk of no arousal threshold OSA. We also cannot find association of PM2.5 with OSA with or without no arousal threshold. However, the detailed mechanism underlying this specific association between the nitrogen dioxide and no arousal threshold also remain unclear. So in the coming future, I think more work can be done, more collaboration we can done in Taiwan to see what is the detailed mechanism about the impact of nitrogen dioxide. The last study is the actual effect of non-methane hydrocarbon on cardiorespiratory hospitalization, which is a multi-cities study in Taiwan. In previous study, they are mainly focused on the health effect on like PM, nitrogen dioxide, ozone, as I mentioned. But actually, very few study keep an eye on those ambient non-methane hydrocarbon, or we call this as volatile organic carbons. In this study, we include 8 major cities in Taiwan. The non-methane hydrocarbon data were collected from 20 live stations in these 8 cities of Taiwan Air Quality Monitoring Network during the study period from 2014 to 2017. And same as previous study, the cardiorespiratory hospital admission record in 8 cities of Taiwan were collected from National Health Insurance Research Database. In the first stage analysis, we used a generalized additive Poisson's model, and then we adjust for temporal change, seasonal variation, weather conditions, and calendar effect to determine the city-specific effect estimate on the lag 0 day. And then we do the random effect meta-analysis to prove the 8 city-specific effect estimate to obtain the overall association of non-methane hydrocarbon with hospital admission for respiratory and circulatory diseases. Here shown the time series plot for the temporal change and seasonal variation of the cardiorespiratory hospitalization and also the non-methane hydrocarbon exposure across the 8 cities in Taiwan. And here's the result show the estimate city-specific relative risk of cardiorespiratory hospital admission for 0.1 ppm increase of non-methane hydrocarbon and the pooled relative risk, which demonstrating that overall there's 0.9 and 0.8 increasement of hospital admission for respiratory and circulatory diseases after we've increased 0.1 ppm of non-methane hydrocarbon. And further, we adjust for PM2.5 and ozone because they have similar impact, maybe a similar impact on pneumonia. So we adjust this PM2.5 and ozone, and then and see the result. And we find that there's a little bit change only, and the pooled relative risk increase a little bit. The overall effect estimate show the association of non-methane hydrocarbon with cardiorespiratory hospitalization. The association was robust after we adjust the PM2.5 and ozone, and the result was published in Ecotoxicology and Environmental Safety. In addition to the cardiorespiratory hospitalization, actually we also apply the same data set to determine the effects of individual species on neurological effect. In this study, we select B tests, okay, in our analysis. B test is benzene, taurine, ethylbenzene, xylene. They are the major aromatic hydrocarbon emitted from combustion sources or even come from industrial solvents. And this figure shows the estimated effect relative risk of neurological hospital admission for 15.8 microgram per cubic meter increase of total BTAX and the pooled relative risk, which demonstrating an overall 1.6% increasement of hospital admission for neurological diseases. And then we subdivided the BTAX into individual species, B, T, E, X, and pooled relative risk demonstrating this overall 0.9 to 1.8 increasement of hospital admission for neurological diseases. Here's the summary of the study. The short-term exposure, short-term ozone exposure is associated with pneumonia, hospitalization in elderly population in both Hong Kong and Taipei, and both long-term and short-term traffic-related air pollution exposure may be associated with the sleep quality and increase the risk of low arousal threshold ulcer. And then the airborne VOC exposure increased the risk of respiratory diseases-related hospital admission in Taiwan. And then further finding on the association of individual species like BTAS, we can also observe the association with neurological hospitalization in Taiwan. In conclusion, on one hand, we can observe at the beginning that PM2.5 is decreasing, but ozone is increasing. And there's a more challenge in the coming future because it's quite difficult to control the ozone, as I mentioned. And we can also observe the significant health effects of ozone and their precursors like VOC on respiratory diseases. Okay, and so in the coming future, I think we need a more integrated management framework linking energy, environment, health, and climate unit that should establish more synergistic mitigations for VOC, NOx, and ozone control. And finally, I would like to thank my research team and also my collaborator in Taipei Medical University, Professor Bai, Professor Zhang in School of Public Health, and then Professor Zhang and Dr. Liu in the School of Respiratory Therapies. Okay, thank you very much.
Okay, thank you, Dr. He Jianhui, for your brilliant speech. And you used the 3 studies to demonstrate the effect of air pollution exposure on the respiratory related diseases such as pneumonia. Okay. Later we will have more discussion on this topic. And right now, let's move to the first speech, also the last speech, from Dr. Wei Chen. Dr. Wei Chen is a distinguished investigator and director at the Center for Neuropsychiatric Research of National Health Research Institute, NHRI in Taiwan. And he also a distinguished professor in the Department of Public Health and Institute of Epidemiology and Preventive Medicine in National Taiwan University. And Dr. Chen's research have linked psychiatric genetic epidemiology and public health with neuropsychiatric medicine, and it's very successful. And very outstandingly, he got outstanding research award obtained from National Science Council of the Taiwan twice. Okay. But recently and very specially, he also obtained a certificate of merit from Taiwan central government because of his excellent performance in anti-drug project. Okay, in Chinese, okay, he is a 反毒有功人士. Okay, this means he's now only an excellent medical doctor and medical researcher. He also a true public health worker and leader. And today, Dr. Chen is going to speak to factors related to mental health distress among healthcare personnel around a community outbreak of COVID-19. It is a multi-site, multi-professional survey in Taipei. Wow, this topic really hit the most trending issue for Taiwan today. Let's welcome Dr. Chen Weijian to the stage. Dr. Chen, please.
So now, thank you, Professor Lin, for your very kind introduction. Today, I'd like to thank the organizer to give me this opportunity to share with preliminary results, because this survey is not formally sponsored, but through squeeze of, my position is money. Oh, okay. So we do not have many support staff to carry out, but because we think this is very important, so we still try to accomplish this survey. And before I get into the detail, let me make a very brief introduction about the background. I think the first survey on people's mental health in Taiwan was conducted in the early phase of the pandemic. That's between April 10 to April 20, a very short period of time. And also, they recruit responders through Facebook advertisement. So sometimes it's not easy to know the generalizability of the result, but that's a very early glimpse of the data. And then I show you two meta-analyses, and they find something very similar. One is physician and nurse have high prevalence of distress and insomnia compared to other or general population. And a second meta-analysis said healthcare workers experience more anxiety and depression than workers in other fields. So I think it's very clear. A healthcare worker, because their nature of work, they have to care for people infected with the COVID-19. So apparently, they are more likely to have anxiety or depression and feel stress. So this is some more detailed result of the online survey. And what they found is, for physicians, if they receive academic lesson, then they have, less the stress about the situation. But for a general person, general population, non-healthcare workers, there's no such effect. So that tells us these two type of population, they need different kind of information to make them feel more, less stressed. Okay, and this is the meta-analysis, and as we can see, physician and nurse have a very high prevalence, 41.2% of distress and 47.3% of insomnia. So that's two common situations. And another meta-analysis also found, during the outbreak, their anxiety increased, and also their anxiety, depression is higher than non-health professionals. Okay, so now back to our study. And our aim is very simple. We just like to know, because Taiwan have a relatively good control of the pandemic. And we did not see much confusion in our healthcare system. But this is not to say our healthcare workers, they don't feel increased stress or other mental health issues. So we like to have some study about their experience. So we collaborate with Taipei City Hospital. Sorry. How to do it? Okay. So we approach 4 branch and recruit their employee, and we do not have any specific limitation, as long as they like to participate in the survey. And we use the RedCap system to help them complete the survey online. But they need to be included by the head of nurse, okay? And so it's very different from, recruitment on the Facebook or the internet, because we like to make sure they are really employee of the Taipei City Hospital. And our data collection started in March 2021 to October. And to some extent, we are lucky because during this period, we have a community outbreak. People may have some memory, right? And so we probably have some chance to look at the impact of community outbreak. And to our surprise, well, the outbreak may have increased distress or some other work-related pressure, but not their general mental health experience. So it kind of interesting, and maybe there are some reasons. So our final sample size 1,033, and our team, in addition to myself, we have Dr. Liu Xinzhen. He is the director of the medical affairs of Taipei City Hospital, and himself is a psychiatrist. So during the survey, we have a design, because we like to make their survey is anonymous to researcher. But if their score above some threshold, so the system will generate some signal to us, and we send this signal to Dr. Liu, and only he has the power to see who the responder were, and then contact those people and try to offer them help. So we try to balance between research and some service or help. But it's also lucky for us because most of those people, they only have a very minor emotional problem, and basically they just can deal with after talking with their colleagues. So that's our experience. And then we have Dr. Jiang Bohua. He's also from National Health Research Institute, and Dr. Lin Yanfeng also from NHI. And we also have 3 assistants. Okay, and let me explain why in our analysis we used May 15 as the cut point for the community outbreak. So now let me show you the data. This is the COVID-19 in Taiwan. So, you know, if you look at today's number, it's very high. Yesterday we have 30,000, right? But people don't feel much, you know, panic. However, last year we have only, for example, 47, less than 50. But at that time, people think it's, a big issue. And I think that because, before this outbreak, we have almost very few COVID-19 cases. So let me show you the data. From May 14 to 15, the case number increased from 16 to 41.7. And if we change into per million, okay, so that means there are 0.67 per million to 1.75 per million. So it's almost double. So we choose to use the May 15, 2021 as the cut point for the community outbreak. But I'd like to remind people, because this outbreak is much smaller compared to other countries. And this may also explain why we did not see much impact on healthcare workers' general mental health, okay? But this is not to say we did not find any correlate. We did find some, but those correlate are more related to their personal experience before the outbreak and not directly related to the outbreak. So maybe our study offers a glimpse on relatively mild outbreak on healthcare's mental health. And I skipped some general questions here because, as you can imagine, we need to ask about their duty and their experience of the resources shortage or some other issue. But for the mental health, we choose 3 specific questionnaires. One is the Pittsburgh Sleep Quality Index, and it have about 7 dimensions. But for my presentation, I just put a global score, and according to previous study, if you have a PSQI score greater or equal to 6, that means you have poor sleep quality. So more score means worse quality of sleep. And then we have the CESD, that's for measuring depression. And my own study indicate, a score greater than 29 represents something to depression, and you probably need some professional help. But in this study, very few people, exceed 29. So we will lower the threshold and do some preliminary analysis. And for the general anxiety disorder 7, a score of greater or equal to 10 represents a reasonable cut point for identify general anxiety disorder. Okay, so that's the 3 scale that's relative well established. And it's easy to find the norm. So it's easy to make some multi or cross-country comparison. So we are in the stage of discussion with Columbia University team. So maybe in the future we will compare Taiwan's data with data collected at Columbia University. Okay, so now let me give you some general background, because our total sample is 1,033, and about 599 collected before the outbreak, and another 434 after the outbreak. And as you can see, the male proportion increased after the outbreak. And the reason is very simple, because at the beginning, physicians are not very few physicians were willing to participate. But after the outbreak, we are more successful in recruiting physicians. Okay, and then for the age, it's probably similar, and also for the 4 different branch, you have very different pattern, because for one particular branch, they have very few employees, agree to participate. But after the outbreak, we have much, employees from this particular branch. So the distribution among 4 branches are not even before and after the outbreak. And it's also very reasonable that after the outbreak, the distribution of professions are different, because, as I said, after the outbreak, we got more physicians recruited, and also many other health professionals. That means, a variety of therapists or pharmacists, those kind of health professionals. Also, we were able to recruit supportive staff, and although their number is much smaller, but our American collaborators feel this very great, because in the U.S., if you like to recruit those people, you need to negotiate with the labor union, and it's very tough. So they did not recruit people like administrative staff or cleaner or security guard. Okay, but in our survey, we were lucky to include those kind of employees. And I'll show you later, in comparison to healthcare workers, they feel less stress after the outbreak. And then if we ask them about any work-related contact with the COVID-19 patient, and as you can imagine, after the outbreak, people with this experience increased. So that means, this survey have some reasonable proportion distribution. Okay, and if we ask specifically about the past week experience of resources shortage, or whether they received instruction on allocation guidelines. And why we ask this, because in the U.S., when the hospital is overwhelmed, physicians need to make a hard choice whether to turn away certain patients and only admit specific type of patient. And many physicians express they are very stressful to make that kind of decision. So one of the studies indicates if the hospital have a very clear guideline, then it's more easy for physicians to follow. So we ask this kind of experience. But our data show very interesting, because if we look at the shortage, like in testing kits or personal protection equipment, and after the outbreak, the only significant difference is people have more experience of personal protection equipment shortage, although the percentage is not very high. And then we also have more expense of a shortage of manpower. Otherwise, there are not significant difference. But about the instruction on allocation guideline, all in terms of 4 items: respirator, beds, medicine, or resuscitation. It turns out more or higher proportion of people recruited before the outbreak receive this kind of instruction. But after the outbreak, less proportion. So I think there's 2 possibilities. One is because they're already familiar with the guideline. So hospital probably feel do not need to make the instruction again. Or to the opposite, they are too busy. Okay? They don't have time to explain those guidelines. But we don't know which one is the correct one. And then we also ask about something about COVID-19. For example, whether they like to get tested or really get the testing for the COVID-19. And those increase, I think that's reasonable. But at that outbreak, still only a very low proportion of healthcare workers there were put on isolation. But the most important finding is the proportion of people willing to be vaccinated before the outbreak. Remember, those are healthcare workers. In principle, or presumably, they are at high risk, right? But only 37.8% like to be vaccinated. But after the break, it increased to 96.8. So you can see, even for healthcare workers, if a community do not have any COVID-19 case, they don't see any need to be vaccinated. So that's a very important factor to explain Taiwan's vaccination rate. That means the number of cases. For example, now we have a outbreak of the Omicron, and you can see now people line up to get the vaccination. So very similar to last year's experience. Okay, I'm running out of time, so I skip to some more important ones. Okay, and but in terms of the 3 questionnaire, when we compare before or after the outbreak, there were no significant difference, and even cut into binary, and we don't see any difference. But if we compare health worker versus non-healthcare worker, for the continuous score, there's no difference. But if we use a binary, then we see healthcare workers have higher, poor sleep quality and more depressing, but not differently in that. Okay. And finally, this multivariable logistic regression, and because, as I said, we are in the process of data analysis, I do not have time to make a better table to show the detailed result. But after we control a variety of covariates, and for the poor sleep quality, the 2 correlates, high pressure or existing physical disease. But for depression, if the person have traumatic experience or pressure or help seeking for mental health or physical disease. And for anxiety, if he feel alone or have a traumatic experience, pressure or help seeking for mental health. So make a very brief discussion. Our findings indicate after the community outbreak, the most obvious thing is people's willingness to receive vaccination increased. And also they report more distress and anxiety. But if we use the 3 well-established questionnaire, then they don't show significant change. But the important distinguishing between healthcare and non-healthcare, that means, healthcare workers have poorer sleep quality and more depression. And in terms of the factor related to mental health distress, first one is the pressure. So that means, if you have a very busy schedule, and that will create a lot of stress on healthcare workers. And then this also similar to other country studies. That means, on average, 50% of the physicians experienced burnout during the pandemic. And although Taiwan is not very, or Taiwan's the situation or the magnitude of the outbreak is much smaller, but still, pressure appears to be the one most consistent correlate of people's poor sleep or depression or anxiety. So I think in the future, how to prevent the occurrence of burnout is important for our healthcare workers. Okay, so probably because of time, I will stop here, and maybe later we have some time for discussion. Thank you.
Thank you for that Chen's speech. I think the time is too short for you to finish. Maybe later we can arrange more time for you. Okay? But actually, we still have Q&A discussion. But unfortunately, originally we have 20 minutes, and just now the secretary told me, okay, we only have 10 minutes. Okay, so life is short. Discussion is short. So for online participants, you can use the raise hand feature, okay, to ask the question you want to ask. And if your question is taken, okay, and please identify yourself with your name and also your organization name, then we can identify you better. But also, okay, because we also have on-site participants, I prefer on-site participants that you can ask your question or comment first. Okay, I'm waiting for your comment and question. Okay, Dr.
And thank you for all speakers. I have learned a lot. I have one question for Professor He Jianhui. It's very interesting that during COVID-19 pandemic, the traffic volume decreased, and PM 2.5 decreased, but ozone still increased. It's so interesting, but why? Is any suggestion or any reason you observe why the ozone still increase, and so you observe the association between ozone and the low adverse health effect? Any question, any suggestion for us? Thank you.
Thank you. Thank you for your questions. This is a very good question. I think many atmospheric scientists also finding why. But from our observation, there's two reasons for why. Because first is when particulate matter is decreasing, it means that a lot of like nitrogen dioxide also decreasing. Much of the pollutants in the atmosphere is decreasing. So the ozone formed, they don't have any pollutant to react with. So we call this as a titration effect. So this less pollutant react with ozone, then ozone will accumulate. This is expected to happen in urban area. Okay, so that's why ozone will increasing if a lot of pollutant decrease significantly. This is one of the reasons. And the second reason is like PM, like NOx, most likely is from those combustion sources. But as I mentioned, ozone formation, one of the major precursors, volatile organic compound, which is we all daily use in our daily life at home or whatever. Okay, hairspray, whatever, any cleaning agents. Okay, especially in COVID-19, many people using solvent. Okay, like alcohol, different types of solvents for cleaning. So this is also the sources of ozone. So that's why even we know that during the pandemic, a lot of activities reduced, but actually the sources or the precursors of the ozone, like VOC, still in a very high level, or we can say that remain unchanged. So that's why the ozone in most study during the lockdown, they still very high. Sometimes it's increasing. Okay, so this is the two major reasons.
So,
I am Wanda Estenfor from School of Public Health, Taipei Medical University. I have one question relating to mental health in healthcare worker. Thank you, Dr. Chen, for your presentation. As you mentioned that in your presentation, there is no change between pre and post-COVID in mental health. But there's still, when you compare with the population, there was higher mental health in healthcare worker. But several previous studies reported that the fear of getting infected and then transmitted the COVID to the family, healthcare worker, mental health issue has been associated with the fear. But in Taiwan, do you think that in your implication, you stated that they need to prevent the occurrence of burnout? Do you think that the pressure is associated by the burnout or by the fear of getting away from the family because of COVID-19?
okay, you want to ask education have any effect on the effect, right? Yeah. Yes.
Your question is very important, and also we would like to know, but because we, in our survey, we failed to include questions more formally to explore whether they have experienced a burnout. So we cannot say empirically. Yeah. But through our indirect experience, because our healthcare workers already have a very tight schedule before the outbreak. So after the outbreak, they have even longer hours of working. And I think that's another issue. So a couple of days ago, when I had the chance to make some presentation to the Central Epidemic Control Center, and I make a brief review. So I said, you know, in the past, about 50% of physicians experienced burnout. And according to the U.S. survey, 1 out of 5 physicians decide to quit in the next 2 years. So that will bring a lot of manpower issues to the U.S. healthcare system. But in Taiwan, we do not have very specific data on this. So maybe in the future we need to ask. Now we have a chance because now we are in the stage of preparing for a follow-up. So for the same responder, if we got approved by the IRB, then we will ask them to fill the online survey again, and then we may include some question about burnout. Then we will have a better idea, whether this important issue or the fear of being infected per se. Okay, but now I don't have any clear answer.
I think that's a very important follow-up, especially after this huge outbreak. But may I continue to ask that, so we found that before and after the outbreak, the mental health status, including depression, anxiety, and sleep scores, actually they do not increase significantly, and it's actually inconsistent with previous findings. So do you have any reasons why is it like
First, I'd like to remind the audience, we recruit in two different time periods. So these two groups are not the same person. So probably, when we recruit during the period after the outbreak, only those people, they feel easy, they can participate in the survey. And healthcare workers, they already in distress, they may decline to participate in our study. So that's one the limitation of our study. But if we succeed in apply to the IRB to conduct the follow-up, then we have a chance to look at the repeat data, longitudinal data. But in my slides, when we compare two groups, they are two independent groups. They just divided by the time of recruitment. So that's the shortage of processional comparison.
I'm so sorry, our Q&A session is still. Okay, maybe for on-site participant after this session, we can discuss during the coffee break. Okay, I hope you enjoy the first session, and now we have 15 minutes coffee break. Okay, thank you.
So our second. Hand.
Hi, so good morning, everyone. I can say it's really good to see you all still in person here today, because we just got notice that almost all the important universities in Taiwan, including with TMU and also NTU, just decided to transform into online for all this from next week. So it will be the last chance to see all of you in person. So it will be my honor to chair these sessions entitled International Assistance and Humanitarian Aid. So although recently almost all the research focus is on the impact of COVID-19, but we should remember that still international aid is still important, especially in this globalized world. So today we will have 3 speakers in this session, and then 2 of them will present either online or in person here, and 1 will use the pre-recorded videos. So how we would like to go through this session is to have the 2 speakers talk first, and then start our QA for a while, and then we will finally move to the pre-recorded videos for the last speakers. Okay, now so let me introduce our first speakers. Professor Masamune Jimba from Tokyo Universities. Hello, Professor Jimba, are you online?
Yes, hello. Good to see you again.
So, may we? Oh yeah, hello. Professor Jimba is a distinguished professor in Tokyo University. He is not only the chair of the Department of Community and Global Health in Tokyo University, but also a president of Japan Society for International Health. He has close connections with TMU Global Health Programs. So we really miss you. We really miss your talk in person on site, because we haven't seen you also for 2 years. So we miss you that too. So from my understanding and also my observations, Professor Jimba is not only excellent in research, he is really a philosopher in the global health. So every time I listen to his talk, I learn quite a lot, especially from the thinking perspectives. So let's give a big welcome to Professor Jimba, and then if you are ready, please proceed. Thank you.
Professor Tsai, thank you very much for your kind introduction. And I also thank very much for Dr. Chen Yu Chen and Dr. Yi Fu Chen, the president and dean of the TMU and College of Public Health. So let me share my slides now. Can you see my slides?
Yes.
Okay, thank you very much. I'm Masa Jimba, teaching global health for about 20 years in the University of Tokyo. And the topic, my topic for today is beyond decolonization in global health. This word is getting popular in the global health literature in the last 2 or 3 years. So I decided to take up this issue. And the contents are 3: colonization, decolonization, and beyond decolonization. Different from the first session, I do not use statistics and numbers, so please relax to listen to my presentation. About 10 years ago, Richard Smith, he used to be the chief editor of British Medical Journal. He wrote one essay and, saying that we should go beyond global health 3.0. And we should move toward global health 4.0, which means researchers from low and middle income countries lead research and other activities, or in short words, we should not behave like donor-driven. Maybe this is the condition of decolonization, but before moving toward this topic, I'd like to describe a little bit more about what is colonization. This is a typical definition of colonial medicine or tropical medicine more than 100 years ago. They were designed to control colonized populations and make political and economic exploitation by European and North American powers easier. And Japan also was colonized a long time ago. So we also maybe behaved like this. However, in the current world, we are kind of overcoming this situation of colonial and tropical medicine. However, some global decolonizing global health researchers often discuss we are still under colonization. There are some colonial remnants in global health. The first is practice level. Some research and practices are still donor-driven. And once you have experienced in international cooperation, you might have this experience. The second level is institution and organization. I'll show you some specific examples in the next slide, but representation represents in global institutions mostly come from the US or Europe. And at the policy level, a lot of money is spent on aid, but the money flow and human resource flow from poor nations to rich nations are much bigger. Let me show some numbers. This is an article written by Richard Horton in The Lancet very recently. He said the president of the World Bank and executive director of UNICEF, always Americans, director of Global Fund, and Gavi, always European and American. And this is the institutional level of imbalance of power in global health. And he said we should move forward to change this power balance situation in global health, or else decolonizing global health is difficult. And 4 or 5 years ago, Jason Hickel wrote this book, The Divide. And as I mentioned a little earlier, the net financial outflows from poor nations to rich nations. That's 24 times compared with the global aid flow from rich to poor nations. It is also expressed as a brain drain from low-income countries to high-income countries. So this is the reality. And this is the remnant of colonial situation. And if you look at the field situation, now war is on, a conflict is ongoing between the Russia and Ukraine. And when I was about 35 years ago, 28 years ago, I worked in the Palestine, in the Gaza Strip on the West Bank. Those days, the situation was peaceful. But after I left, this high wall was started to be built between Israel and Palestine. And because of this, people in Palestine lost their freedom to move. And sometimes children had to go through the crack of the walls to go to their schools. And this is the photo of a hospital behind the wall. In the past, it took only 5 to 10 minutes to go to the hospital for the people living around here. But now it takes 2 to 3 hours because of the move of the wall. So this is a kind of colonized situation. In 2014, Gaza Strip was bombed like this, and the same thing is happening in Ukraine. And colonization takes place in this kind of physical space. But now digital colonization is ongoing in many parts of the world, I believe. But the typical one is here, is this one, in Palestine again. Dr. Harari wrote in his book, whenever Palestinians make a phone call, use Facebooks, they are monitored by Israeli microphones, cameras, drones, or spy software. And the Israelis control the sky, airwaves, and cyberspace. By this, surprisingly few Israeli soldiers control about 2.5 million Palestinians in the West Bank. I think this is a typical type of digital colonization. And this may be taking place in other places too. And this is a kind of data dictatorship. And the AI, artificial intelligence, makes it possible to do it. So how we can overcome this will be the current and the future problem regarding colonization, which is beyond the global health. Let's move on to decolonization. Decolonizing global health is defined like this. You know, these articles have been very frequently appear in BMJ and Lancet particularly. Kam and Dr. Bimbora define decolonizing global health as like this. This is a movement that fights against ingrained systems of dominance and power in the work to improve the health of populations. And one conference was held in Wuhan about decolonizing global health. And they showed the direction of decolonizing global health by showing guiding principles such as peace, human rights, and justice. And they agreed that we should build global consensus to remove practice of colonial remnant, which I explained, but it's very difficult. And then we should move towards a multipolar global health governance, which Richard Horton also mentioned about. And then finally push for a paradigm shift to believe that through continuous economic and social development, the low and middle income countries can solve its own health problems by themselves. This is the stage, the ideal situation of decolonizing global health. And at country level, we could see some hopeful move. Oxford, they moved international secretariat from UK to Kenya. And this is a momentous shift of the center of leadership from north to the south. And I think this is very encouraging. And regarding this, coming back to this, related this one, push for a paradigm shift. The Palestinians said, without decolonizing Palestine, decolonizing health is difficult. So at global level, this Palestine paper is published in this website, Action to Decolonize Global Health. If you go to this website, you can see a lot of articles about what we should do to decolonize global health. And there are some proposals. London School, Harvard, Hopkins, they said we should make the school of decolonizing global health. Then health metrics and evaluation, they said they will create a decolonizing index to be applied to any global health intervention. Another group said we should make a decolonization task force for all NGOs and for all schools of global health. I think TMU has global health, School or Department of Global Health, so you may be asked to make decolonization task force to make a fair international cooperation. This is the current move for decolonizing global health. And here is Dr. Sei Abimbola. He's one of the advocates of this decolonization movement in global health. And he said to decolonize global health, we have to remove all forms of supremacy. It does not limit it to white, to black, to white, to Hispanic. This is true even among one country, not the color of the skin. We can find this kind of supremacy, a wrong balance of power everywhere. And he also mentioned if the future is a radical transformation, global health will be unrecognizable, and we may have to give it a new name. I don't know what it is. Maybe he does not know what it is, but he's telling this in the Lancet. And this is my boss, Professor Wakai. Before Professor Bora mentioned this, 20 years ago, my professor said, ending global health is the goal of global health. By this, we lose our jobs. But this is what he said. This is because achieving equity and social justice is our ultimate goal. So if we achieve equity and social justice in global health, we don't need to continue this. This is what he mentioned. And when I make this statement in my lecture to students often ask me, how do we know the situation of achieving equity and social justice? And then I tell them, this is a regulative idea, which is, it can never be realized. But we can never forget it. It is something we cannot do without. The voice of the regulative idea may be faint, but it will not cease until the idea has been realized. It's an idea, something like achieving eternal peace by Immanuel Kant. And no matter how it is denied or repressed, it will always return. So achieving equity and social justice, this idea will come back again and again and again. And even if we cannot see the achieving level of equity and social justice, we keep moving toward this goal. And after we die, we transform, we transmit this regulative idea to our next generation. Then beyond decolonization. So in the same document, they said it only focusing on decolonizing global health movement is not enough. We have to decolonize the world political economy. And we have to continue this movement in parallel with other movements to decolonize, so for social, economic matters and others. And again, I emphasize his statement, a radical transformation, what it is. And some scientists showed this iceberg metaphor for global health. And it shows 4 levels. The superficial one is the event. And this is based on Western colonial mental model with keywords such as Western centrism, paternalism, and others. And based on this, colonized aid programs are implemented. But we have another model, African populations mental models. The key was a plural identity, or foundation of human relationships, or relation with God. And this African populations mental models may be similar to Asian populations mental models. And in order to make global radical transformation, we have to go into depth, mental level. Assumptions, beliefs, values the people hold about the system. And this level of transformation is necessary. That's what they mentioned. But we don't know how long it takes. But stepping away from this Western-centric universal scientific rationality might be necessary for decolonization. And I show you another model for radical transformation. This is the 3.5 rule, which is proposed by Erika Chenoweth. She is the professor at the Kennedy School at Harvard, and she analyzed nonviolent movement in the world in the history. And she said nonviolent protests are twice as likely to succeed as armed conflicts. And those engaging a threshold of 3.5% of the population have never failed to bring about change. And this is the data she showed in her YouTube video and in her books. And she said nonviolent campaigns make sense. And this must be something you must experience in Taiwan too. And she showed an example of the Philippines in 1986. But the question is whether this 3.5% rule can be applied for global health, or how examples are taking place at country level. But global health taking place at global level, then we should listen to her advice. it requires imagination and creativity. It requires organization, and it requires courage and discipline. So this is something what we need as global health practitioners. And even if our drop is very small, this must be a very meaningful. So let's continue to keep having and giving a drop in the ocean of global health. Thank you very much for listening.
Thank you, Professor Jimba. Like what I mentioned, Professor Jimba is really a philosopher. Always he brings the ideas for us to rethink again and again regarding the importance and the ultimate goal of global health. So yeah, now we have to move to the second speakers, and then we will have the QA after this speech. So the second speakers of is Miss Gina Guo, and she's the lecturer of our TMU Flying, a student groups who working in the developing countries for some activities, and also she's also a candidate of TMU College of Public Health. Let's welcome Gina Guo.
Thank you, Professor Tsai. And hello, everybody. Good morning and almost good afternoon. I'll try to finish up on time for everybody to enjoy your lunch. And I'm so pleased to be here to share our stories about how we manage to build WASH facilities during COVID-19. There's not so much about research, but about the experience, how we accomplish this project. So I will first talk a little bit about our organization and what's WASH and how do we implement the program in rural Cambodia. So Fly Young all started with a group of students from different majors in Taipei Medical University. And to avoid the colonization, what Professor just talked about, we have three very important core values to hang on to, which is localization, sustainability, and also empowerment. So let's look at the map of Cambodia. Here is the capital, Phnom Penh. And here's the World Non-Heritage Angkor Wat is located. This is Siem Reap. And while most of the international aid, or NGO, NPO, they'll focus their resources and their efforts in these two countries, Fly Young decided to move a little bit further to the rural part of Cambodia, which is called Battambang. And we work with schools, primary schools there to help them to become health promoting schools. Oops. So in the early stage, we serve most as a health message provider. We deliver and translating health message in the local community. We also do lots of observation and communication with the community to know the needs of theirs. And later on, we start to distribute first aid kit and help to set up the nurses' room in every school. Also, we work with Shenzhen University to build classroom and WASH facilities in two of the schools there. So when the COVID hitting the world in 2020, both borders of Taiwan and Cambodia was locked down, but we still managed to continue our supply of the first aid kit through lots of help from lots of organizations, and also include some important tools to prevent COVID-19, such as thermometers, masks, and sanitizers. And our students also managed to continue their health education via technology with two organizations in Siem Reap. And the highlight today will be how we scale up our WASH program during COVID-19. So let's talk about WASH first. What is WASH? WASH stands for water, sanitation, and hand washing facilities. People will ask me, this facility seems to be more relevant to people are familiar with environmental engineering or architecture. Why would you jump from a health message provider to build all this hardware facility in the campus? So all the story starting from this study was done by Horichi, the researchers. While many of the nutritional study in Cambodia focus on children under the age of 5, this is the very few study that focus on school children. And because all the past efforts in nutrition intervention has worked so well, so the percentage of the malnutrition status for kids under 5 actually dropped dramatically in the past years. But when the kids entering school, because there's no much nutrition intervention focused on these children, you can see there's a trend going higher and higher on their malnutrition status. So it means when they grow older, they are more likely to be stunting, wasting, or underweight. And these children who are not able to reach their growth potential, they are more likely to have higher rate of mortality, and their cognitive development will be damaged. And also, they will, when they become adult, they earn less money in the future. And studies have told us that nutrition-specific intervention, like giving supplement to these kids or giving them higher intake of energy or protein food, only can fix a very small part of this problem. Why? Research tells us there might be an abnormality of gut function, which is called environmental enteral dysfunction. That was caused by environmental contaminants, which will impair their nutrient intake. And what's the risk factor for this dysfunction? Open defecation, drinking water quality, sanitation, and lack of hand washing facility is all the keys. So does this sound familiar to you? Yes, this is everything all about wash. So on our part, we started to take anthropometric measurement for the school children with all kinds of methods. And these kids were so excited because could be the first time for them to have their height and weight measured after they were born. And everybody get a card to record their height and weight in each year and their gender and their age. And we also put them in our database. And this picture is really by accident because you can see there's a boy on the left-hand side. He's practicing his open defecation. So we can see a little bit from our raw data. This is the girls' part. As for height for weight, you can see the bottom line of numbers. These girls have a way below height compared with the reference that was recommended by WHO. And you may ask me, okay, this population might be shorter compared with the world population. However, if we look at the BMI, it still be lower. So our students try really hard to do all kinds of health education and communication. We do posters, we do nutrition education, we also do modeling, and we try to teach what's the food classification with all kinds of activities. We also do posters, storybooks, and we also do our illustration on a calendar to promote personal hygiene behavior in a calendar for the student to bring home to share with their family. And we also do workshop with all the principals from the region. And we tell them how important it is to become a health promoting school in order to help the kids to be healthier. We also do survey to check on all the wash facilities in each campus. So even we got 3 checks on all the things relevant to wash. I think we are all set on the wash, right? But if we take on a virtual tour around the campus, this is what you will see. So some students might start their day from bringing water from the pond next to school and put them in front of the classroom. But are they using the water? No, it's more like a routine for them to, like something they learn from the textbook, but they never know and they never use the water. So in the end of dismiss of the school, they will empty the bucket and just go home. And some kids will use water from the river like this. And some schools are lucky enough, they can use the water if they are next to a temple. They can use the water belongs to the pond. And some will get water from a manual pump like this. But with a school of 400 students, they share only this pump in the school. And this is, some of them will take water from the well. And do they treat water? Yes and no. We can find there's one white bucket on the right-hand side. This is actually a ceramic filter system that was shown very effective to remove environment contaminant in science, but it shows no signs of usage. Okay, and let's look at the sanitation. If we give 5 stars for the sanitation, this is probably a 3-star toilet they are using. It looks fine, right? There's water and there's a toilet. But what about the water? Where does the water come from? No, so they have to carry water every day to fill up the tank over there to do their business. So most of the time, either teacher or student, they don't have extra energy or extra time to carry the water. So most of the time, the door was kept locked. And because sanitation is so precious in the community, so sometimes you will see toilet was stolen or damaged. And this is the condition of the door. So locked also. And this is probably the 5-star toilets in the community. But however, what's the problem? They got this funded by a corporate. But with this spacious and bright toilet, there's no hand wash facilities near the toilets. So there's no place for them to wash their hands after they do their business. And this is one of the very few schools have a fancy hand washing facility like this. But what's the problem? It's too high, it's too tall for the young kids. So we were playing a washing games, and our students actually have to help all the students to wash their hands so they can get their prize. Okay, and there's another problem. Because it's so precious there, all the wash facility is so precious there. So everything was either fenced or locked. So when we come back, we ask ourselves, even we give them all the knowledge, even we encourage them, and they are willing and they know they have to perform the personal hygiene behavior. Are they really able to perform this behavior? So we ask ourselves, in academia, oftentimes we explore the problem and we give recommendation. But this time, can we try to fix the problem? But as a school-based organization, it's not so easy, especially sustainable and enough funding is the first challenge. So we happen to know that the Rotary International, they offer money, they offer funding to build wash facilities in different countries. But can we apply? No. We have to go through a regional Rotary Club to apply for the money. Oftentimes we say we need stakeholder to enter the field, but we also need stakeholder to enter the door to our sponsor. Because there's already tons of organization and programs are standing outside knocking their doors. But we are so lucky. Our former president in TMU, Dr. Hu, He is the very important and active member in this Rotary Club, which is the Rotary Club of Taipei West. So we actually got a key to enter the door. So with the schools and Club of Taipei West, we got a grant called Global Grant. With this grant, we are able to build a wash facility, also provide health education for the students. For the wash, we plan to do biosand filter system to provide them self-drinking water, and also build hand washing facility for the student to use, and help to restore their toilet. With this plan, we can benefit 10 schools and 4,500 students. For the health education, we hope to cooperate with local young artists. And with our database targeting health message, we hope the message we created incorporate both quantitative and qualitative data to make the message really effective. So with the health education, because the lower cost but the bigger impact, we can manage to give 71 schools, 30 communities, and hope to reach 21K children in the region. And how do we implement the program during COVID-19? Because we really cannot physically be there. And lots of time, both countries are a little bit in a status of chaos. Some of the time, those people were not allowed to travel across the border of their village. And it also takes lots of communication with the two sides, not just with the schools, but also with our sponsor too, because their bad story happened before. Their sister club used to sponsor one of the wash programs in the country, and their money was taken away, and the construction never happened. And these people, they rarely know the schools we work with. So I spend lots of time to do communication with our sponsor. So what do? I do more than they ask for me to do. So we first do a very detailed survey about everything, every status, including how many people, what's the sex ratio in the school, how many teachers, and how many students. And we try to do their geographical location with their GPS numbers here to show our sponsor. And we ask the principals in the school to draw a school map for us, so our sponsor will know what's the condition of the school. And it's interesting, you will receive all different kinds of maps from different schools. And on my side, I try to do web search on the possible model to build, because I have never been into environmental engineering or construction. So it's important for me to have a very clear picture about what facility we're going to build. And these are the facility we can find on the web, but not many. This is almost the best. So when we talk a lot about capacity in the pandemic, I also want to maximize my capacity of my facility. So you can see the previous pictures. There are only very few faucets in the facility. So with the very limited amount of money, I want my hand washing facility to maximize its facility. So it was designed on both sides and with different height, because remember that our students have to carry the younger kids to wash their hands. And how do we decide on the height of this hand washing facility? We pull out our data, we take out the mean and the mode, so we give recommendation for the architecture who design for these hand wash facilities. So first we give them pictures like this, but the principal told me, no, I still don't know how to do it, because this is so rare design in the local community. Then we have to do the math. So we try to know the size of the bricks, and we count it. So we tell them exactly how many bricks and what's the size of the hand washing facility from all different angles. And we even have a spot for them to wash their feet. Okay, and for budget-wise, this is not so common in the local community. Everything was talked through oral communication. A written budget is very rarely seen in their daily life. So I spend lots of time working with our schools to detail everything they might need to expand. And let's see what we have accomplished. This is school 1. So all the people we work with really share every detail about the construction. So I started to know how the sausage was made. So they even share how do they cut the metal, and starting from scratch. And this is a roof that is not planned in my plan before. But all the school asked for a roof above the hand washing facility. I think this is a very important lesson because the country has the rain season for half of the year throughout the year. So it's important for them to have a shelter to practice their behavior. Okay, so this is how the construction worker work on the roof. And in the end, this is the principal on the right and his brother. They have to finish up the project because the worker they hired, they told them they have to do farming now. It's the harvesting season, so they have to leave. And then our principal have actually to finish the project by themselves. But they are so happy. And this is the end product. It's not so close to what we have designed because we designed for 2 heights. And but I think it's good enough for us. So this is the principle. This is a drinking facility they designed by themselves. It's easier for the student to drink water. And this is school 2. They enjoy showing their selfie to us, to share everything. So they choose different types of tiles. And you can see this is the most close to our design originally. And with $70 US dollar, you can help the school to actually restore the water resource in the school. So they were so happy to see the water finally coming out. And they no longer have to use that dirty water in the classroom. And this is the restroom. So they redo everything. And this actually a mistake I made before. Then you can see the pipe coming out from the hand washing facility from outside. And in the beginning, this is the project I work with Zhejiang University. We thought it's so green. We can recycle the water for them after they do their business. But one day, the principal told me, oh no, they also use the water to wash their private part after they done their business. So with this project, we are able to redo the direction of the pipe and fix everything, put on the tile. So this is a brand new tile, a brand new facility. For school 3, they already have all the fancy facilities. During the COVID, they got funding to build all this. But what's the problem? They are using the pound water from here. So if the water pressure is not enough, they are not used to get the water to actually flush all the facility or get the water coming out for the faucet. So the only thing they ask for is a huge water tank like this. Okay, this is actually a video for the student to show their appreciation to our sponsor. And hope with this project, the health education and the wash in the nurses' room, we can help this school to become a health promoting school in the future. And what lesson I learned from this? First, you have to choose the right communication tool in this whole project. Among all these apps or programs you see here, which is very popular for us during the pandemic, I have to give Facebook Messenger the crown because that's the only app they are using. You can only reach them with this. None of the other things in the previous slides. And also, you have to update your sponsor before they ask for your report. All the transparency and the timeliness is very important for your sponsor to trust you to spend all their money. And in the pandemic, people ask us to keep social distancing, and also we communicate everything with devices. So in this time, I think name and faces are very the key to establish rapport with both sides. So I actually spend lots of time familiar both sides with each other with name and faces, so we can reach our agreement more easily. And last, because we just talked about decolonization in global health, so I think meet the needs for both sides if you could, but when you have to choose, if there is a conflict, you always have to put the school and the community you work with as your priority, because there's really an imbalance of power in this cooperation. So you are the person who is able to communicate to minimize the harm to this community. And the last, I think this is really important for researchers to take on, that water filter system is really not on the wish list in here. I think maybe it's not, they don't know the importance or for the consequences if they use dirty water or contaminated water, or because it takes too much time, or I don't know. But I think this is something we need to take on. Why, if even it is available there, but they are not wish to use it. And thanks for listening, everybody.
Oh, thanks, Gina, for the excellent presentation. It's always good to see the action from the young generations, and then we are excited to see that happen. Okay, so I guess before the next speech, we have several minutes for the Q&A. So I would like to invite all the participants, either on site or online, to raise your questions to the two speakers here. So yes, please.
Okay, thank you, Gina, for your wonderful presentation for today. And my name is Pyro from the School of Public Health. Well, I very admire for what you did for the project that you did in Cambodia, because it's remind my experience there before about last 10 years. And then we saw so many things like weakness about the public health. But I mean, I want to ask you for two questions by here. Did you observe for their families? Because once when I checked for your presentation, and then you try to present about what you did intervention among the schools, right? But I think several dimensions is reintegrated together. For example, the families, that's really important one, right? And the second one is, well, based on my experience, and I think you also feel that also, Gina, because when you run the long terms of the campaigns or volunteer like this, the important thing is what is the follow-ups, right? I mean, after what you did, and then is that, you know, it's made your criteria, it's made your aims or not. So that's really important when you run the interventions that you need to check the follow-up after your program. So that's all about two questions for that.
Okay, thank you for your wonderful questions. And because we focus on school-based intervention today, so I didn't show much about the family part, but I think there's a lot of challenge and difficulty that lots of NGO, NPO is facing, because we really have limited resource and people we can use. So I think it's really important to incorporate family in this project, but right now it's still a dream for us, but we'll try, yeah. So about the follow-up, actually when you apply for the global grant, they have a really strict evaluation form for you to fill up to tell us how do you evaluate the program. So it's not including in this step, but there are some different steps that we will evaluate, not by us, but by the school themselves. Yeah, thank you.
Thank you for your presentations. And regarding that, the WASH projects, I would like to raise a few discussion points. Most of the projects, the challenging point is the sustainability.
Yes.
So the sustainability, number one, is the availability of the water. So in your presentations, there may be implementation, but it's not there. So number one is that they should apply the natural hydropower from the a little bit higher gravity level use the pipe, from then go down to the floor, and then there will be the collecting tank. Second is the Cambodia is also the raining season. They have we see the roof, but there should be the drainage system to collect the water as well. There's another source of availability. And the second, another thing is I didn't notice the soap supply that, but because using water alone is not really effective or somehow. And then another point is that when they use the latrine, the rural area, they sometimes use the stick for the cleaning as well, the stick.
The stick?
Yeah, after toilet. The
Oh,
rural,
the stick.
yeah, so
Okay.
it usually block the the drainage of the water, fly-proof latrine kind of. So it also usually we observe, because I've experienced in Thailand, but Cambodia is more or less the same situations. So so it really block to the toilet, and then that's why they usually lock there. And then the village leader use that as a garage to store something inside, not really applying somehow.
Yeah.
Yeah. And the last is that the evaluations of the effectiveness of the program, that should be attached to the survey on the diarrhea disease or some nutrition program. Then we can see how effectiveness of the implementation area. Yeah. Thank you so much.
Yeah.
Please identify yourself in the end.
Sorry, I'm Win from Global Health Programs.
Okay, yeah, thank you for your valuable experience sharing. So, yeah, I was going to say in the presentation, talking about sustainability in a country like this is really a big challenge. So, we understand that as our observation, all the the pump, they can only last for 2 to 5 years, and then you have to get a new pump. But without the public infrastructure in the country, that's really the best we can do right now, just to help them to replace the pump or replace the motor every couple of years. That's so far what we can do. So my job is to get sustainable funding for them to replace replace that. Okay, so about the roof, that's a very good idea, because one of the school, they actually cannot dig any groundwater, and also in the community. So what they can only do is to buy water taken from other ponds. And we thought about making the roof to collect the rainwater for them, but it's really another big project for me, so I will think about it. But I saw them in the community a lot. All the family household, they have they do their own style of rain collecting systems, and all very creative. I wish I have time to share them here. Yeah. And thank you for the next two about the soap and the management. Thank you.
Okay, thank you. I guess we can only have one quick question, especially if possible, for Professor Jimba, if possible. So we have one questions from the online participants. So he can directly ask questions online here. Yes, please, Budi.
Thank you for your presentation. I am Budi from Global Health TMU. I have a question for Professor Jimba regarding the decolonization of global health. I'm so surprised and interesting to your presentation, because you are very open, explain about how is it. Really, it's new insight for me about global health and about decolonization. Especially when you say decolonization of global health cannot global health cannot be achieved without decolonizing Palestine and so on. And my general question is, how it is possible about decolonizing global health? You said one of the global health 4.0 in global health 4.0, researchers from the LMIC should lead the research. And then we get in decolonizing of global health, we also need to be like independent from the developed countries, while the developing countries should be more independent, not be like directed by the stronger power. That's why we want to remove any supremacy, as you said. My question is, how is it possible, and how far we can go to reach that? Just to get knowledge. Thank you.
Thank you very much for your question. I want to show you two examples. I often teach positive deviance approach. Started in Vietnam, and it started. It is using in 60 countries now. This is a very country-driven, community-driven approach, which emphasizes sustainability and the community's initiative to change society. So this is usually micro-level intervention, but there is a hope. And due to limited time, I cannot explain it more. But if you go to the website, Positive Deviance Collaborative, you can see a lot of examples in different countries. And another thing which might be related with the next speaker's, Ms. Gina's presentation. This is private companies' involvement in international development. One example is in Bangladesh. Japanese government, a private company, and Bangladesh's famous NGO, Black, made a good negotiation to start a new business in Bangladesh. And I don't know whether you are aware of WiMAX, but WiMAX internet system was first applied in Bangladesh. And several years later, it came to Japan. And we are using it now. So this innovation, internet innovation, or practical use started in lower middle income country, Bangladesh. So Gina talked about the source of funding, and you asked Rotary Foundation. But I think Taiwan has a lot of powerful private industries. And if this private industry can make a good collaboration with local NGOs in different countries, you may get a chance to make more fair global health interventions. And in the case of Bangladesh, both Japanese companies and Black could share the benefits, profit from their IT business. So they could make a win-win situation. And the same company did a nutrition program in Africa too, by making some supplements. So this might be a way to go in the near future from Taiwan. And you don't need to worry about the WHO or other UNs. This is private industry and the local NGO in the country. And there's a lot of potentials to do something great. But one day, at the same time, you may have to make a voice at the country level. Related with the health promoting schools, I also had experience of working in Cambodia and Nepal about school health. And a lot of specific activities did not continue long period. But when we made a policy, it lasts many, many years. So if you can do something related with policy, it can be sustainable. And also if you publish papers in academic journals, this academic articles can benefit to the world population, world scientists. So this is another great contribution of global health, which Taiwan can contribute to the world. So sorry, I talked too long, and I finished here now.
Okay, thank you, Professor Juba. Due to the time limitations, we might have to close the QA section and then move to the third speech of these sessions. And so thank you, Gina, and thank you, Professor Jimba. So and then we might have to move to the third speakers. Let me, even though he provided recorded the videos, but I still have to introduce here that the third speaker is the Professor Fan Jiakun. Jiakun Fan here from TMU. He's not only the professor and director of the Center for International Tropical Medicine, but also he is the president of Taiwan Society of Parasitology. So he has a really fruitful experience working in African countries. So now we are moving toward to listen to his talk. So that's welcome. Okay, so now let's start the video.
Every distinguished colleague, good afternoon. I'm Professor Fan Jiakun. Because at the same day, I am entrusted a mission to be the convener of a committee by Higher Education Evaluation and Accreditation Council Taiwan to assess one national university graduate institute. So please pardon me for using video presentation. So today, I'm more than happy and also my honor to be here having a talk about the neurocity psychosis causing seizure control program in Eswatini under COVID-19, challenges and perspectives. Let me introduce the background briefly. Currently, a total of 20 main neglected tropical diseases have been greatly appreciated by WHO, of which 12 are caused by parasitic infections. NTDs threatens the health and life of about 1.5 billion people in the world. High prevalence of epilepsy is partly caused by various infectious diseases, including helminth infections. Noteworthy, teniasis or city psychosis also belongs to one helminthiasis. When larval invasion to the brain by tanium sodium will cause neurocity psychosis, thus leading to epilepsy, then cause huge impacts to family, society, national health, and economics. In 2014, CDC has targeted 5 neglected parasitic infections in the United States as priorities for public health action. You may notice city psychosis is also one of them to be intensively controlled in USA. Again, what kind of parasitic infections may cause NCC? Yes, it's tanium sodium. Humans may acquire such an infection through consumption of improperly cooked pork containing city circus, and then the city circus can grow up to a worm measured in 6 meters long, then resident in the small intestine for several years. The eggs released from the ruptured gravity segments can contaminate the environment, water, and food, while the patient's feces. When pigs or humans ingest the eggs accidentally, the Anguisseria may invade various internal organs, including the brains, thus leading to neurocity psychosis. Surely, seizure is one of the terrible consequences caused by NCC. Well, city circus measure in 5 to 15 meter long can be found lodged on the brain or inside the brain. When these viable larvae taken from the brain, you may find very beautiful thin and transparent clothes embedded one scolex containing 4 suckers armed hooklets. You can see the cute larva is so amazing and elegant. In neurocystic psychosis, focal and generalized seizures are the most common clinical features. In developing countries, about 30 to 50% of all adult onset epilepsy is due to NCC. NCC may be preceded by a long asymptomatic period with no evident inflammation around encysted and viable larvae. However, after treatment by antiparasitic drugs, the degenerative cyst may release complex antigens, thus leading to acute inflammation and subsequent clinical symptoms. Nevertheless, in fact, till now, how to treat NCC remains debates, considering terrible cytokine storms in the brains. Since NCC may cause seizures, how about epilepsy situation in Eswatini? Previous data analysis showed that 11.2 per 1,000 people in Eswatini live with epilepsy. The annual mortality rate per 100,000 people from epilepsy in Eswatini has increased by 52.2% since 1990, an average of 2.3% a year. This aforementioned data attracted my curiosity concerning what NCC plays a role in causing seizure among Eswatini people. In 2017, Dr. Du, Director, Taiwan Medical Mission in Eswatini, trusted a nurse to bring surgically dissected brain tissues, requesting to examine any of the city circuits existed in these tissues from one patient suspected of NCC. So parts of these tissues were used for pathological examination and found the tissue's features fit to the TMU sodium city circus criteria. Partial materials were used to detect anti-sodium city circus DNA using specific COS1 and COS-B primers for PCR. The amplicons were analyzed by sequencing. Thereafter, the sequence data was aligned to BLAST, indicating 96% to 100% identity to T-sodium city circus. So it's bingo. This patient suffered from NCC with no doubt. So I asked to myself, how about the NCC situation in Eswatini? Check from WHO website. I got an information indicating Eswatini is a suspected endemic area only, reflecting no sufficient data to indicate what's the real NCC situation in Eswatini. So it is worthy of further exploration. So where is Eswatini? East, north, west, and the south part is surrounded by South Africa, while its east part is close to Mozambique. Its total population is 1.2 million around. It has been called African Switzerland, so it's a very beautiful country. Yes, I would like to ask, how about the NCC situation in Eswatini? In 2019, we performed a pilot study to investigate any suspected of NCC-infected residents in Eswatini. From 2 provinces, 4 communities nearby the capital, as suggested by the deworming program, were investigated. We utilized door-to-door method to undertake individual questionnaire interview and specimen including blood and feces collection outdoors. Overall, 1 of 28 participants was detected seropositive, along with 1 suspected CT circus found by head CT scan, thus resulting the CT cirrhosis seroprevalence to be 1.2%. Meanwhile, after collection and interviewing, an educational leaflet was given to instruct participants how to prevent T-zolian infection. For example, suggest them not to eat improperly cooked pork and sanitizing hands before eating. Herein, I would like to express my sincere condolences to my long-term partner and old friend, Precious Chief Deworming Program, who tragically passed away in 2020 from COVID-19 infection. Precious is a kind and generous partner who is always helpful. Although COVID-19 pandemic is very terrible, COVID-19 impacted entity health services comprehensively, such as disruption of community-based interventions, delays in diagnosis, treatment, and care services, discontinuation of monitoring and evaluation activities, including population-based surveys and so on. Based on the global severity of COVID-19 from 2020 to 2021, honestly, I'm quite anxious and undetermined whether I should lead my team to continue executing NTDS project in Eswatini. However, after carefully monitoring the COVID-19 trend in Singapore, South Africa, and Eswatini, and also I noticed that a drastic decline from 1,020 cases in August to 34 cases only in September last year in Eswatini. Additionally, to my partner, Google's suggestion, she said, late October is a good timing to go, so I made up my mind to go in late October. You should have known I'm not really a fool, although we are brave enough but not reckless. The doses of vaccination are a must for every member before we go. Everyone from 2 working groups must wear disposable protective suits, surgical masks, and gloves. The working and the rest area will be isolated separately, and all the working procedure will follow the guideline by Taiwan CDC on the COVID-19. Routine self-test of COVID-19 for 2 group members is a must also to keep safe and healthy. Cars are also sanitized regularly to assure my members' safety and health. Participants are measured the body temperature and hand sanitizing before signing the consent, questionnaire interview, and specimen collection. Before commence of the community screening, a meeting for community leaders, chiefs concerning NCC project was held, and adequate explanations to their questions that reaches consensus. Thereafter, we commenced the NCC screening. We employ the GPS device to locate the visiting place and keep the records. We are very surprised but happy to find several private pig farms. This crew is very important to further NCC project. Staffs in collection group must be monitored every 3 days to exclude the possible COVID-19 infection that ensures the next 2 days mission safe and healthy. In short, we are very strict and careful in executing NCC screening project in community that ensures my members' safety and health. The overall city psychosis seroprevalence in 2021 was 0.4%. Only one case infected by Hymenolapis nana instead of T-solium was found by fecal examination. So that means no intestinal T-solium teniasis was found last year. That's really a pity. To sum up, combined data from 2019 and 2021, the overall city psychosis seroprevalence was merely 0.61, very low. Compared to the other studies globally, it seems likely that this figure is very low. But however, 2,000 provinces such as Lumbombo and Sizuwini, where pigs raising farms are common, have not yet been investigated. The real infection status remains elucidated. No kidding, we are really detectives. We continue monitoring the seropositive person's living environment and intend to inspect any CT30 in pork or visceral organs in private slaughterhouse. Unfortunately, workers in private slaughterhouse decline our visit unfriendly and offensively. Thus, we didn't have any data about the CT30 in pork or visceral organs. More terrible, certainly emergent Omicron outbreak makes us in a mess. We have no choice but escape returning to Taiwan. However, to my planning, this November to December, we will come back again. We all know the WHO's Sustainable Development Goals. Among the 17 main SDGs, we are helping end the epidemics of NTDs in Eswatini. That our project fits to the SDG 3.3. We collaborate with Eswatini partners to work together as well as share technology to combat NTDs in Eswatini. That our project also fits to SDG 17.6 and SDG 17.8. So Taiwan can help. TMU is helping. I would like to express my sincere appreciation. My PhD students, Gina, Ariel, May, and Jody, and Aswatini collaborators, including Fortunate, Cindy, Gugu, and Shabangu, as well as local partners, help in this project so greatly. More importantly, Eswatini roasted maize supporting my daily survival should be acknowledged and appreciated here as well. Finally, this is a very shining Taipei 11 tapeworm very close to TMU campus. If you have visited there, you are definitely a cute parasite now, but if you haven't done it, do not hesitate. Please come right now. Thank you so much for your listening and patience. Thank you, Niabonga.
The College of Public Health was founded in 2000 and currently comprises of 4 academic departments. First one is Graduate Institute of Injury Prevention and Control, which offers master's and PhD program. Second one is School of Public Health, which offers bachelor's, master's, and PhD program. Third one are 2 all-English programs, such as Master Program in Global Health and Development and PhD Program in Global Health and Health Security. Fourth one is Master Program in Applied Epidemiology. The first 3 ones have English course among the 4 departments. Apart from the 4 academic departments, we are proud to also have 3 task-oriented research centers, such as Global Health Security Research, Research Center of Health Equity, and a Stroke Research Center. Here are the research fields and features of the different departments. First one is School of Public Health that aims on biostatistics and epidemiology. Environmental health, including Healthy Work Environment Promotion Center, community health, and health policy and welfare. Next one is Graduate Institute of Injury Prevention and Control, aims on traumatic injury prevention, head and spine trauma database, and Air Medical Emergency Commanding Center.
Taipei Medical University was established in 1960. It's located in Taipei's prosperous Xinyi district, near the world-renowned Taipei 101 skyscraper. TMU started 60 years ago with the first 3 schools, medicine, dentistry, and pharmacy, and only 250 students in 3 rudimentary buildings with aluminum sheet rooftops and the bare minimum of medical equipment. Upholding the school motto of sincerity and honesty by students and faculty members, TMU has metamorphosed into a comprehensive medical education network, boasting 2 separate campuses and 6 affiliate hospitals. Revenue from school and hospital management and the number of SCI qualified papers has seen substantial growth in the last 2 decades. Led by a board of directors and successive deans, TMU has made enormous progress. TMU comprises 11 schools and a center for general education, which is home to more than 6,000 students and 46,000 alumni globally. TMU's world-class performance has been consistently recognized by the QS World University Rankings and the Times Higher Education Asia University Rankings. TMU was awarded the title for Best Medical and Private University successively in 2020 in Global View magazine's Taiwan Best University Rankings. TMU's research subjects in clinical medicine, pharmacology, and toxicology are ranked in the top 1% of essential science indicators. TMU expands the horizons of biomedical leaders with its humanity solicitude, creativity, and global vision. Based on the concept that education is not for the present but for the future, TMU's College of Interdisciplinary Studies, echoing the global trend of distance learning schemes, offers visionary microlearning programs and gives students the opportunity to explore cutting-edge fields, including artificial intelligence, big data, and entrepreneurship to cultivate comprehensive, future-ready skill sets. TMU has introduced a state-of-the-art AR/VR digital learning program and established a virtual intensive care unit and operating theater. Through VR technologies, transformative and engaging learning opportunities are provided. TMU offers hundreds of up-to-date learning courses as part of its massive open online course, MOOCs database, attracting more than 100,000 students from Taiwan and abroad, and revamping the traditional classroom learning approach. To enrich students' understanding of humanities, arts, and culture, TMU cooperates with Academia Sinica and the National Palace Museum to give students the opportunity to learn from rich cultural treasures. In addition to classroom learning, TMU encourages students to participate in a diverse array of on-campus clubs and sporting activities. Their outstanding contributions have received local and international recognition, a testament to their selfless service. In terms of research, TMU has established multiple excellent research teams in clinical and translational medicine, with particular emphasis on the areas of cancer translational medicine, neuromedicine and thoracic medicine, artificial intelligence treatments, cell therapy and regenerative medicine, and in the R&D of biomedical equipment and materials, cardiology, urology and nephrology, developing precision health with full support. The quality and quantity of SCI papers has increased annually. Annual growth in research protocols and budget. Increase in annual patent approval and technology transfer. TMU has also established the Office of Data Science for the development of AI and data science, and has established a Precision Health Research Center for charting the course for the big health industry. It has created a medical accelerator and startup venture funds to promote R&D innovations. TMU has also established a few affiliated startups with capital of more than $38 million. 3D Biotech Incorporated will be listed on the emerging stock market soon. At Shuanghe B Base, new buildings for biomedical tech, teaching and research are being built, part of TMU's innovative biomedical system and an important hub for international biology. TMU is actively aligned with the international community and with NIH USA, Johns Hopkins University, Case Western Reserve University, University of Southern California, Imperial College London, Université de Lille, and Hokkaido University. The number of international co-authored papers increases year on year, as does the number of foreign teachers and students, a testament to TMU's effort to achieve internationalization. Ever since 2009, TMU's medical mission teams have been stationed in the Kingdom of Eswatini and the Republic of the Marshall Islands, providing crucial services in maternal and child health, tuberculosis and parasite prevention, among others. In collaboration with the government's policy, TMU has enhanced its cooperation with new southbound countries, such as TB disease prevention in Vietnam, to support Taiwan's foreign diplomacy. Pursuing excellency is an endless path. The Dreamway Building and College of Humanities and Social Sciences buildings were completed in recent years. The construction of the Proton Therapy Center is currently underway, as well as the Taipei Cancer Center and Shuanghe B Base. Aside from the hardware and facilities, nurturing talent plays an important role in TMU's growth. The Leadership and Executive Accelerating Development Program is in its 5th iteration, cultivating more than 100 junior and senior executives. In recent years, TMU Hospital, Wanfang Hospital, and Shuanghe Hospital have promoted a patient-first core value by providing the highest quality medical services to our patients, applying medical big data and Internet of Things, and fostering artificial intelligence such as blockchain, digitalized ward management, and full development of smart hospitals. The specialties of TMU Hospital are cleft palate craniofacial surgery, reproductive medicine, and the Da Vinci surgical system. Wanfang Hospital specializes in cardiology, hyperthermic intraperitoneal chemotherapy, TB prevention, and holistic care in aging. At Shuanghe Hospital, neurology, renal and urology, orthopedics, and organ transplants have all achieved distinguished results. The Taipei Cancer Center pioneers innovative services, including personalized precision medicine, healthcare navigator, and early phase international clinical trials. Taipei Neuroscience Institute leads dynamic robot-assisted innovation on brain surgery and non-invasive therapies for movement disorders, surgery for cerebrovascular diseases, and intra-arterial thrombectomy. Xinguomin Hospital has a particular focus, offers a vision and blueprint for the next 10 years. In the next 60 years, TMU will sustain its deep-rooted education, research, medical care, and internationalization. With its innovative thinking and spirit, TMU stimulates teachers and students' creativity and competence, enhances its social influence, and advances the route toward the most innovative new university.
The College of Public Health was founded in 2000 and currently comprises of 4 academic departments. First one is Graduate Institute of Injury Prevention and Control, which offers master's and PhD program. Second one is School of Public Health, which offers bachelor's, master's, and PhD program. Third one are 2 all-English programs, such as Master Program in Global Health and Development and PhD Program in Global Health and Health Security. Fourth one is Master Program in Applied Epidemiology. The first 3 ones have English course among the 4 departments. Apart from the 4 academic departments, we are proud to also have 3 task-oriented research centers, such as Global Health Security Research, Research Center of Health Equity, and a Stroke Research Center. Here are the research fields and features of the different departments. First one is School of Public Health that aims on biostatistics and epidemiology. Environmental health, including Healthy Work Environment Promotion Center, community health, and health policy and welfare. Next one is Graduate Institute of Injury Prevention and Control, aims on traumatic injury prevention, head and spine trauma database, and Air Medical Emergency Commanding Center. The last one is Master's and PhD program of Global Health and Health Security, the Amazon Global Health Promotion, Climate Change and Infection Disease, Medical Anthropology, and Tobacco Hazards Prevention.
providing me this opportunity of being here as a moderator. You know, for me, it's like when I was a kid, when my parents for the first time allowed me to sit at the table with my dad. So thank you so much. Okay, we have 3 presentations today. We have from University of Singapore. We have Dr. Wei Gao from TMU, and we have Dr. Long from Academia Sinica. And they are going to provide their insight. They are going to provide their insight about precision computing. Okay, so I think we can immediately start. We start with Dr. Teo. So Dr. Itinteo is the Dean of the Associate School of Public Health in the University of Singapore. He is also managing the topic of his presentation. I don't have time to go through his awards and honors and publication list. It's full of impressive. So please, Dr. Teo, you can start your presentation, opportunities and challenges in the use of digital tools for SE prevention and management in COVID-19. Case study on physical activity promotion in Singapore. Thank you.
Right. Thank you very much for the invitation. I hope everyone can hear me. Would I be able to show my slides from my end?
I think I will, yes.
I think I will, yes. Thank you very much. So let me see. If I could just ask Matthias, could you see my slide on your screen?
We can. I can see your slide. I can see your slide. So I'm assuming that you could.
Great. So I'm assuming that you could see my slides and you can hear me. So thank you very much for the opportunity to share with you some of the experiences that we have learned in Singapore. It's a privilege to be invited to share a little bit about what we're doing in Singapore. So without further ado, I think I will just start off by really talking about how the fact that the world is now moving towards a different stage in the way that we use data. And it's very much linked to this effort in precision public health, where it's not just about the use of data for individuals' health, but more importantly, it is the use of capturing the right kind of data that we are able to design better policies to guide governments and jurisdictions in making certain decisions about public health and about clinical healthcare. So when I thought I would share. I think I'm hearing some echo from. Okay. Nope. It's better now. Oh, I'm hearing the echo again. All right, great. So I thought I would really focus on a case study we have in Singapore that is centered around physical activity. And this chart you have in front of you really is a
burden of diseases that looks at the risk factors that is influencing a person's health. And you can see that at the very top, you have issues like high blood pressure, you have issues like smoking, high fasting plasma glucose. Those are really changing the landscape around non-communicable diseases like diabetes, hypertension, lipidemia. But there are risk factors such as high body mass index and low physical activity that really has been contributing to the burden of cardiovascular and chronic conditions. Now, when we start to think about low physical activity, it is quite clear that the lack of physical activity actually does impact health. And we know that there is a international recommendation of achieving at least 150 minutes of moderately intense physical activity in a week. And I always like to ask this question, because it's virtual and it's online, I can't see everyone's response. But if each of you now just take 20 seconds and think about the last week, the last 7 days that you have gone through, did you actually participate in at least 150 minutes of physical activity? And you will start to realize that even amongst public health practitioners or students, this issue of lack of physical activity is a very prevalent one. Many of us know what we ought to do, but we don't actually do the necessary. And it's not just around physical activity. The same problem exists when we think about nutrition. So I'm going to go through a series of steps to really look at how a national program that is meant to tackle physical activity could be designed with the use of digital methods, and at the same time, what is the impact that COVID-19 had and how we could mitigate some of the impact of COVID-19. So of course, the first step is what kind of data are we able to accumulate in order to understand the size of the problem. So in terms of data systems for understanding health, generally there are three types of data that you can think about. One is definitely around population trends. This is looking at the demographics. The second is much more individualized. It's really understanding how people behave. What is the nutrition, what is the physical activity, behavior. And finally, it is around how people are spending their healthcare dollars, where they're going for their healthcare treatment. Is it primary care clinics with the GPs, or is it straight to the hospitals? And all of this has a different impact on the health system. And in Singapore, we were able to make use of some of this information to really start to understand what is the size of the burden of diabetes going to look like in the next 20, 30 years. And given the size of the problem, we realized that it is going to expand more than threefold in terms of the number of the prevalence of diabetes in Singapore. A lot of this is going to be driven by an aging demographics, but you will realize that diabetes doesn't just affect the old people. Younger and younger people are getting diabetes, and that is going to have an impact on the workforce. So when you start to think about the economic burden of a problem like diabetes, you will very quickly realize that actually the medical bills for treating diabetes is just about half the cost to the society given a problem like diabetes. Issues that are linked to the workforce actually cost as much, almost as much as the medical cost. And it's exactly those kind of calculations that we took, that we were able to look at this from an economic angle, that the economic burden from a problem like diabetes, to which physical activity or the lack of physical activity, the lack of good nutrition contributes a significant component to people getting diabetes. And it's already going to cost the country more than $1.5 billion on an annual basis. And this is going to grow even more up to a projected cost of about $2.5 billion per year just from a problem like diabetes alone. And we're not even talking about the other chronic conditions or other conditions linked to infections. So when we start to look at data and extrapolate beyond diabetes, that's where we realize problems like stroke or hypertension, it's going to cost the country a significantly more in terms of the disease burden and in terms of the economic burden. And we were able to identify where those parts of the problem is going to lie. So you will realize that being able to capture the right kind of data, not just individually, but at the community level as well, is going to help us understand how to distribute our resources and resource allocations accordingly in order to tackle the problem of diabetes. Now, I talk about the use of physical activity as a case study to tackle NCD. I'm going to start to describe or to introduce what we consider a health promotion program that is digitally enabled. And how we digitally enable this is through the use of trackers. You would say that traditionally, the way that we capture physical activity on an individual, for an individual, is through the use of personal recall, that you remember how much physical activity that you participate in. But those kind of recall actually has its disadvantages given its lack of precision, and often we like to think that we exercise a lot more than we actually do. So technology has changed tremendously, whether it is the use of wearable trackers or your mobile phone can now track your daily physical activity. And by designing a national program that is giving everyone a tracker. So this is the National Steps Challenge program that we have in Singapore. This is the 5th year that was rolled out in India. And we have data for the past 5 years. So it meant that now we are able to understand whether the use of such trackers are likely to be useful as a national program to incentivize the physical activity and what are the benefits from it. So the National Step Challenge actually gave everyone to sign up
刚刚测试的那个
that
软
tracks
体
their
可能就是
physical
我说那个
activity.
设后方式是可以
Beyond that,
对，
there
那
is
就是他
also
们要
incentives
连回
that are
VPN， 然
given
后要给我
to
电脑它
individuals
它本机
if
电脑
they
的名称，
manage to hit certain targets. So if you are able to
电脑名称
achieve
太难
a
了。
certain
对啊，
number
对
of
学生来
points,
讲，
which you will earn points if you accumulate
你懂
more
我
than
意
5,000
思
steps
就
a
是
day, 7,500 steps a day, or even 10,000 steps a day, you get additional points.
除非
And for every bundle of points,
礼拜天要陪我
able to
上线。
translate that to a monetary
对，
reward
我跟远端没差
that，you can use
就是你要陪我
to
上
pay
线
for
去
your
处理这件事
grocery
情。
bills. So we're very conscious not to
我
tie
会看电脑名称
to
吗？
expenses that
我要教他们
linked to whether
可以啊，就是当场给我，我马上远端进去修改也可以啊。对啊，对，可以啊，只能这样，是可以。
popular in Singapore. It's not going to help a lot if you let
不，
people
我跟你没关系，那
exercise
礼拜天的事
only
情
certain vouchers to spend on bubble
可
tea.
以啊。对啊，
This
这就是
translates actually for
上午一场，下午一场。
and of course we can't
对
track
啊，他
what
就是
people buy
马
for
上提供给我他的电脑名称，然后我马上加进去。我就开那个 Google Meet，然后你就进来，然后你就看每一个会分，就是可能他在聊天室写，哦，可以啊，然后你就是复制，然后帮我贴上，可以啊，可以啊，你这个到几点？4点。6点。那我没办法，我等你啊。你方便上来，因为我现在已经设定好，然后我让你看一下那个界面是怎么样。等6点的时候，中间会有休息，我再来。好，好，马上去。可以哦。那你名单你还没传对不对？还没。好，那你再记得传一下。对，好。辛苦。那你有跟芊芊说名单的事情吗？就是你要用这个方式，他说的让你选择看你哦，那就好了。
On average, it's about 1,000 steps more. I will come to discuss whether this 1,000 steps more actually mean much from a health perspective. So right now, this is what I would consider process data that people were tracking the physical activity before they started the step challenge, and then after they started the step challenge, where the incentives kicked in. How does things look? Now, the question has been, what happened during COVID-19? And this is a chart from January 2020 all the way up to August of last year. So about slightly more than 1.5 years of COVID-19. And the vertical axis actually shows the number of steps on average on the median daily step count of the participants. And because these are already participants wearing their trackers, we were able to know what the step counts look like. Now you would see that there are two vertical bars that are colored in pink. That it refers to what we would call lockdown in Singapore. So during COVID-19, many countries, many jurisdictions actually implemented some form of lockdown where people don't go to work. Some public transportations are actually shut. In Singapore, we never shut public transportation, but during those two blocks, people are encouraged to work from home. And you could see very clearly that there is a significant impact to the number of steps that people take. That before the start of the lockdown, steps were around 9,000 a million, but the moment it started, you see that it drops tremendously down to about 4,000. Now, then throughout, you would see that even after the lockdown, when Singapore again regained some degree of mobility, the steps count never really recovered. That it remained fairly low, despite the fact that people now can return to work and can go out to the public and move about in the parks and so on. But the steps count never really went back up. But when when Health Promotion Board announced the launch of a new bonus round for the National Step Challenge, this was when there are additional incentives given to people to encourage them to move more. Then again, we start to see that steps count start to recover again. So that's a clear indication that COVID-19 actually did affect significantly health-seeking behavior as measured by physical activity, as measured by step count, but the availability of incentives to nudge behavior actually did help recover some of it. Now that was on steps count, and if you look at the definition of moderate to vigorous physical activity, because now some of the trackers were able to chart heartbeat as well, heart rate, so we were able to get a sense of whether some of this physical activity would be considered to be tagged as moderate or vigorous. And you could clearly see again that the duration of some of this moderate to vigorous physical activity dropped quite significantly, more than half. It decreased by more than half. But incentives were able to drive it back up. But any time that society introduced some degree of lockdown or restrictions to moving about the public, again, this physical activity will come down. So it's actually something that we would know without having this direct tracking. But what was interesting was the fact that the availability of incentives actually nudged people to go back to recover some of this physical activity that they would have lost otherwise. So, given that we learned some of these insights in terms of what an outbreak can do, this is where having this partnership with private sectors, whether it is with Fitbit, whether it is with Apple, to really try and incentivize the use of trackers, and to use these trackers to incentivize, to provide monetary financial incentives, or even just health coaching. It's able to now drive people to pursue a lot more health-seeking behavior beyond physical activity. So Lumi Health is another iteration of a national program that is digitally enabled. This is a partnership between the Singapore government with Apple, and it's making use of all the people who own an Apple Watch, that they are able to sign up again to another national program that goes beyond just physical activity, but also include wellness as well, in terms of mental wellness and sleep patterns and so on. Now, the last part I wanted to talk about is very quickly around effectiveness of the national step challenge. We've talked about the cost. On average, it costs about $100 to enroll and to provide the incentives for the national step challenge. The question always is it going to help the government save money, or are we just giving money out without really getting any health benefits or future health benefits in return? So that's where our disease modelers, together with our health economists, started looking at this from both the direct cost perspective as well as the societal impact. And this is where we included things like sick leave, productivity losses, early retirement and mortality or productivity losses because of illnesses. The take-home message is that actually the National Step Challenge, if we operate on the basis that we currently have, it is not just cost effective, but it also is cost beneficial. There will be cost saving from a societal perspective. And that is a sign for our government to really decide on how do we scale up this beyond just physical activity, but also to look at other forms of interventions that is digitally enabled that may have an incentive component. So the summary that I have today is really that the use of data for policy setting is a very powerful approach, and governments worldwide are starting to make use of such information to decide on their health priority setting. At the individual level, digital tools now really change the landscape in the way that we measure and we capture impact, the environmental exposure, and what individuals are doing. But more importantly, it's not just a way of capturing information around the individual, it is also a way of incentivizing or to send nudges to change people's behavior. But at the heart of it, when we think about digital tools, we have to always remember that there is a need to assess whether these digital tools are truly effective, and more importantly, that the benefits that we get is more than the cost that we're putting in, because all of these digital tools will cost a lot more than traditional health promotion in public health. So with that, thank you very much again, and I look forward to the question and answer session at the end of it. Over back to the moderator, please.
Dr. Teo, for your wonderful and very precise and accurate presentation. Very interesting to learn more about how we should behave in terms of physical activity. So, as for the previous sessions, the question time is at the end of the three presentations. So, I would like to invite the second presenter, so it's Wayne Gao, to step in. Okay, so Wayne is basically the reason why I'm here. So he's the one who hired me first in Taipei Medical University. He got his PhD in the US from New York University, and before coming back to Taiwan, he worked for almost 10 years in Switzerland as the director of the International Union Against Cancer. So his expertise goes way beyond pure academic research. He's interested in comparative studying global health and health security policy, international tobacco and cancer prevention and control, health promotion and communication, global health resources, governance, and leadership. Recently, he published several papers, and just to mention the two most important, one on Ghana internal medicine and one on animals of internal medicine in the last 2 years. Today, he's going to talk about non-communicable diseases and health promotion in the era of COVID-19. Please, Wayne. Thank you.
Thank you, Nadia, for introducing. Thanks, Dean Chen, for organizing this great event, especially in this very challenging time. And especially first, I think the society needs to reconsider the risk management in terms of living with virus and with precautions measures. And I think this is what we are doing. And time really flies. It has been 30 months since the pandemic started in Wuhan. And about 28 months since the WHO declared global pandemic emergency. And so in this presentation, I'm going to talk about a few big change that actually the pandemic is going to affect us in the following years, not in the long run. So according to the study, that 1 in 5 people is actually increased risk. 20% of the population, they are more at risk when they are infected. So we have seen the big disruption of the NCD prevention. A lot of people, for instance, recently in Shanghai, so many people with diabetes and hypertension who are not able to get their meds. And this might not be a direct impact from the COVID infection. This is also the health burden that comes with the pandemic. And are we seeing a big increase in health risks behaviors? So we just saw Dean Hill, YY is actually a friend of mine, says there's a reduction of physical activity during the lockdown in Singapore. And I think this probably is quite universal, that the health behavioral change during the COVID. And are we going to see an increase of health risk behavior? Will people smoke more, drink more because of pandemic? And is this behavioral pattern going to last? So also about the indirect effects. Are we going to see that because of all this healthcare service disruption, are we going to see more NCD hits, more NCD burdens in the future? So another big reflection is our healthcare system. We have seen a decline in healthcare usage. So it might be also an opportunity to analyze what we call overdiagnosis, overtreatment, overuse of medication. That could also affect our health. So let's check this do more rigorous review of application in PubMed. It's about 140 articles. So every year, in the last week, almost we have more than 100,000 COVID articles. So it is actually the very researched disease. We pay so much attention on this particular. I don't know why this. Okay. So this is our earliest publication in COVID. 2 months after the regional declared emergency, we published this paper on the healthcare workers in China. Next. We also have a few commentaries in BMJ. Next. And this is our foundation health biblical, because we like to emphasize a very important idea about COVID direct impact and COVID indirect impact. We need to see overall population health. Next. And this is our results. We have seen that because we don't have a lot of COVID, and really the first wave of global pandemic, Taiwan actually sees a decline in pneumonia. And that's because of non-pharmaceutical inventions, which also benefit others infectious diseases. Next. Okay, this is our another disease modeling. We actually proved that mask was really useful in early transmissions measure. Next. Okay, so going back to NCD, as you can see from this slide, between 1990 in the last 30 years, we have seen the global burden of NCD has increased twice a year. And this is partially due to the population growth plus population aging. But as we face this centuries global crisis, we can actually expect to see that there is impact on NCD. Next. So this is 3 measures we try to contain the pandemic. One is non-pharmaceutical, and pharmaceutical now we have vaccines, very useful vaccine. And we also have very powerful antiviral drugs, and of course some supportive treatments. But most importantly, in terms of NCD, is about social economic determinants of health, disparity, equity, and public policy. In the morning, we have heard Dr. Jim talk about equity, talk about decolonization. And these are the underlying determinants of health that will eventually determine how big the burden of COVID is going to be across the countries. Next. And in this Lancet paper, it says the term caused by cancer will demand for greater attention on NCD and social economic inequality. Next. And we have, before COVID, the United Nations already decided, we are going to have 2025 global NCD targets. And in the last two years, we have this big interruption. So we will probably see a huge delay in reaching this global target of NCD. Next. So some studies already found that physical activity has been declined, as also being here also showed in Singapore. And also increasing in sedentary time and consumption of unhealthy food. Also the rate of depression. We have a few talks on mental health this morning. There is an increase due to social isolation. People are not able to have common social contacts and normal interaction during the lockdown. This all has some mental toll on us. Next. And another very important idea about this overall impact of the pandemic is access deaths. And this is a very simple graphic from economists. Look, you compare to the historical average, we can see the deaths attributed to the COVID, but we also see actually much bigger total that are not directly impacted by the COVID, but indirectly. And I found a very interesting pattern that in a country where healthcare population surveillance are more professional, more precise, you don't see the huge differences. But in countries where population surveillance are not as well, you can see their reported cases are much lower than access death. That means there's a lot of either underreported or those health burden indirectly influenced by COVID. Next. So we have pseudo-demographic factors we need to consider. We have biological factors. We need to know the virus. We need to know if the vaccine works. But we also need to pay attention to the existing chronic condition of individuals and also health system. Next. And these are the chronic conditions that could exacerbate the COVID outcomes. Mostly are people with chronic conditions, kidneys, neurological, even liver diseases. Next. So in general, most studies found that there is a negative effect on physical activity and restrictions, lockdown. They all have changed our behaviors. Next. Okay. For instance, obesity. There are already some studies, but even during the 2008, the global economic depression, some empirical studies already have found that diabetes and obesity has increased during the societal crisis. Next. And also alcohol consumption increased. And they used the online sales data. They found that increase in the US increased more than 2 times. Next. And I found this very interesting. We have an article from Italy. Also, I have data from Taiwan. In the last 3 years, the consumption of cigarettes in Taiwan has actually increased. And for smoker, if they feel stressed by all these pharmaceutical measures, they increase their consumption of cigarettes. And this might be the indirect cost of COVID. Next. And WHO has done this very interesting review about the services being code for non-communicable diseases. Next. You can see in most countries divided by the WHO regional office, almost all healthcare officers reported there is significant disruption of healthcare services. People are not able to receive proper care for their chronic conditions. Next. And these are the percentage of country reporting disruption due to the NCD-related services. And these all come with costs. Next. So health promotion. So now we emphasize this One Health concept. We have to also understand that animal welfare, genomic factors affect health, and also, very importantly, climate change issues. So we shouldn't only focus COVID pandemic as a biological factor. Actually, it is beyond the factor that pathological point of view. Next. So this is another article about implementation of NCD policy. A proper response is to implement the NCD policy, such as reaching the national NCD targets and national action plan. And as you can see, the green bars, you still have so many non-communicable diseases policies not implemented by so many countries. Next. So I have a few suggestions. We need to understand how how disparities affect the impact of the pandemic across countries. And because we know that the pathogen doesn't affect people evenly, they actually are quite discriminated against more vulnerable people, or people in chronic condition, or people in lower socioeconomic status. Next. So we need to monitor the possible behavioral change altered by the pandemic. For instance, during the COVID, South Africa actually banned smoking. And a lot of people probably think that why during the pandemic we banned self-smoking. But we already, in a very early stage, we already have research found that smokers are at greater risk when they are affected by the COVID. Next. And this is we need to research the more systematic and socioeconomic determinants of health. This is the results from the economists. As you can see, in terms of per 1 million deaths, excess deaths, you can have countries as high as more than 1,000, as low as less than 50. So there is actually more than 20, 30 times differences across the world in terms of the million deaths. So that is actually a very interesting indicator that different countries responding differently results in such disparity in the burden of the pandemic. Next. Okay, I'd like to close my talk in this quote by Churchill. He said, "Never let a good crisis go to waste." I think COVID is a once-in-a-century global crisis, but it is also an opportunity for us to reflect a lot of very rooted fundamental issues ingrained in our society, such as disparity, inequality, and justice. So let's go beyond the biological paradigms to a more wider, broader scope, spectrum of the societal issues that we have. Thank you.
Thank you, Wayne, for your comprehensive overview of the possible consequences of COVID-19. So let's move to the third and the last presentation of this session. Dr. Long from Academia Sinica is going to give her speech. She is Research Fellow and Deputy Director of the Research Center for Environmental Changes in Academia Sinica. She is also adjunct faculty with the Institute of Environmental and Occupational Health Sciences in TMU and Deputy Executive Secretary of the Center for Sustainability Science in Academia Sinica and many other things I don't have time to list. Her education was in Harvard, PhD and Master in Environmental Pollution, Environmental Health Management and Air Pollution. And her research areas are, of course, exposure and risk assessment, organic aerosol, environmental health management, health adaptation, heat stress, heat vulnerability assessment. She has a number of very, very interesting publications in journals such as Indoor Air, Journal of Exposure Science and Environmental Epidemiology, and one of my favorites, Science of the Total Environment. Today, Dr. Long is going to talk about providing precision prevention strategies to reduce PM2.5 health risk from research-grade low-cost sensors. And to me, especially from my previous experience, the low cost is the key word here. Thank you so much. Please, Dr. Long.
For the introduction and invitation. I hear some echoes. Is everything okay? All right, I'm going to share my slides. Okay. Well, good afternoon, everyone. And today it's my honor to be here. And today I want to demonstrate how to use research findings using research-grade local sensors to provide precision, prevention strategy to reduce PM2.5 health risks. As we all know that higher mortality of COVID-19 actually occur in areas with higher air pollution. And currently the most concerned air pollution is PM2.5. PM2.5 defined as particulate matters with aerodynamic diameter equal to or less than 2.5 microns. It's a human carcinogen causing both acute and chronic disease, and including NDC. Okay, and let's look at the world's 20 capital cities in 2020 under the impact of COVID-19. Actually, the top two are cities in Asian area, and the top two had annual concentration about 8 times higher than the previously recommended PM2.5 target. That was 10 micrograms per cubic meter. And last year, WHO just announced the new guidelines. The new annual guidelines for PM2.5 is actually 5 micrograms per cubic meter. That means that the urban population in most of these cities are actually, those population are living in an environment with unhealthy air. And let's look at the progression of, okay, well, my screen is frozen right now. Let me check. Okay, all right, let's look at the progression of PM2.5 from source emission to health impact. EPA monitoring station located in 10 meters above ground actually measure pollutant in ambient air in a well-mixed environment. And however, if we want to looking at the concern about the health impact, we should concern about the concentration right in front of our noses. That's human exposure. Okay, it can be assessed by personal monitor and personal sensors. And since on daily basis, we are all encounter certain emission sources nearby. So we may be exposed to peak exposure much higher than the ambient levels measured by EPA. However, most of the PM2.5 epidemiology study using ambient level to represent human exposure. And from a famous US study, we all know that, okay, because these scientists in a US study, they use more spatially resolved PM2.5, and then they obtain 4 times higher PM2.5 damage coefficient. It shows that more accurate estimate for PM2.5, then we will get more accurate estimate of PM2.5 damage coefficient. And by using research-grade local PM2.5 sensors, we can actually assess peak exposures, which are difficult to be assessed by EPA monitoring station. And these peak exposures, which may cause immediately or acute health impact. And also, by using these local sensors, we may identify the activity associated with this peak exposure and health impact. So we can provide precision preventive strategies for individual citizens to reduce their health risks. Here is PM2.5 concentration distribution when we walk down the street of a 400 meter by 400 meter community. And as you can see, because we may encounter certain community sources such as traffic emission, direct traffic emission, and restaurant, temples. So the concentration, the exposure concentration may be 3 times different. So the exposure level actually is a combination of the ambient level measured by EPA's monitoring station, plus the contribution from community sources and personal activities. So we have to minimize all three of them in order to minimize exposure level. By using research-grade local sensors, we are able to quantify the incremental contribution due to community sources and personal exposure and personal activities. Currently, EPA worldwide, they have regulation focused on large industrial sources, which contribute to ambient level, and very few regulation focus on community sources. So we may have evidence and to ask the governmental agency to really have more regulation targeting community sources in order to reduce the overall personal exposure of PM2.5. Okay, so here, if we want to reduce the health risk of PM2.5, we have to reduce the exposure levels, and then by using local sensors, we can provide evidence to control for community sources. We can also identify activities, so we can advise individual citizens to change their behavior in our health promotion package, and so they can interrupt exposure pathway in order to reduce their PM2.5 health risk. And 30 years ago, we used this type of filter-based samplers connect to a pump, and it is very heavy and also noisy. And for 24 hours, we can only get one data point. That is the mean concentration for the past 24 hours. Only one data point, very low time resolution. And 20 years ago, we have this research-grade real-time PM monitor with 1 minute resolution. However, it is very expensive. 5 years ago, we integrate these wearable low-cost PM sensors. It's lightweight and small. It can measure PM2.5, temperature, humidity, GTS, and activity level in one set with 15 seconds resolution. So it can be used in our research. And so these local sensors, we call it AS-LUNG, shortened for academia sinica. And lung is actually the organ affected by air pollution the most. And there are 3 types of AS-LUNG. The outdoor version can be connected to solar panel, so we can set up in any place with sunshine. We can set up in the outdoor patio of household. We also use the indoor one, and also we have this portable one to assess personal exposure. And this one can be combined to a micro health sensor, so we can assess we can evaluate the health impact of PM2.5. And for local sensors, the major challenge is data quality. We actually build up a customized chamber, specialized to calibrate this type of local sensors. So we calibrate against research-grade instrument. For this EDM 180 is actually a US EPA FEM instrument. And as you can see, AS-LUNG can be applicable up to 400 microgram per cubic meter. And also the slopes are different in different concentration ranges. So we actually apply segment regression for calibration curves to convert our readings. So you can see after conversion, we have very high R-square and low variability and low root square error. So for each and every one of our sensors, we calibrate them before use. Okay, my screen frozen again. Okay, let me try again. Okay. Okay. All right. So with these local research-grade local sensors, we recruit 3 different panels covering different area of Taiwan with different age ranges. And basically, these subjects are non-smoking subjects without a cardiovascular disease. They carry sensors for 2 to 7 days and maintaining typical daily activities. And at the same time, they have to fill out time activity diaries for every 30 minutes. So they indicate in the microenvironment they stay, their activity, their ventilation status if they stay indoors, and also the exposure source they encountered. This is very important for later data analysis and also for later precision preventive strategy recommendations. And so here I show a result based on a panel 26 non-smoking subjects recruited in northern Taiwan, age 40 to 75. They carry AS lung for 7 days. And at the same time, we also set up household outdoor and indoor monitoring. And also we ask them to fill out questionnaires for their general characteristics and also household conditions. And here is the result for PM2.5 and PM1. And today I'm going to focus on only PM2.5. Here are 5 minutes resolution with personal exposure at indoor outdoor levels. You can see we have really huge sample size. And you can see the mean concentration maybe only between 10 to 20 micrograms per cubic meter. However, when a subject encounters certain emission sources, their exposure could be up to 200 micrograms per cubic meter. So since we have their detailed time activity and we also have these sensors with 15 seconds resolution, so we can actually plot the time series of this PM2.5 concentration. This is the example for the incense burning at home. The pink one is the personal exposure levels, and the blue one and the green one is the outdoor and indoor levels respectively. We can see before the incense burning, the indoor and personal levels are really low. It's about only 20 something. And during the incense burning, the indoor concentration could be increased up to 200 micrograms per cubic meter, and the personal exposure could be up to nearly 90 micrograms per cubic meter. It shows the contribution of this activity to the subject's exposure. And we can do the same for several examples. For example, the cooking at home and cooking at battery or exposure at the restaurant. And this is like a case study. And we have 26 subjects. We have 7 days of their data. So we can compile them together to do statistical analysis. And here, we calculate the indoor-outdoor ratios. The IO ratio means, the IO ratio larger than 1 actually means the indoor level is higher than outdoor level. Okay, and so we focus on the condition when the subject stay home under the condition of window open, window closed, and air conditions. We also classify their different exposure sources. You can see that cooking is the source. Those subjects exposed the most. However, it is the incense burning had the highest IO ratios in window open, closed, and air conditioned condition. The IO ratio could be up to 6 and 8 under the window open and closed condition. The actual exposure level could be up to 180 micrograms per cubic meter during incense burning, and one event may contribute to 40% of their daily PM2.5 exposure. Since we have this detailed data, PM2.5 exposure, and also their time activity, so we can give individual advice to ask the subject to advise them to change their behavior in order to reduce their own health risks. Okay, let me try again. My screen is frozen again. Okay, maybe it needs to take a while. Okay, another study is focused on a panel of 33 non-smoking healthy subjects recruited over Taiwan, and they carry AS lung and another health sensors for 2 to 4 days in both summer and winter. And this health sensor is medical certified sensor to assess heart rate variability. And HRV is actually a very important marker for autonomy balance, and it is associated with cardiovascular mortality. And for this panel, the mean exposure level is relatively low. It's only about 30 plus minus 9 micrograms per cubic meter. However, as you can see later, we can still see the significant health impact. We use GAMN to do the statistical analysis. And our model is adjusted by age, BMI, indoor-outdoor, season, and activity levels. So for this low exposure range, we can still obtain significant change in their HRV indicators, such as SDMN and low-high frequency ratio. For an increase of 10 micrograms per cubic meter in PM2.5, we can observe significant reduction of SDMN by 3.4% and significant increase of low-high frequency ratios by 3.6%. And we can also see the impact will last for 5 hours. Okay, so red dot actually means the statistical significance is lasting for 5 hours. And the greatest change of SDMN is right after exposure. However, for low-high frequency ratio change, the greatest change is occurred 2 hours after exposure. So because we have detailed time activity patterns, so we can identify the major activity associated with peak exposure and also these significant health impacts, immediate health impact. So we can plot the frequency distribution of this major activity associated with peak PM2.5 exposure and also the significant health impact. Okay, here is the example focusing on vehicle emission, incense burning, cooking, and ETS. We can plot the activity associated with this exposure. So by providing data to government agencies so they can change their health promotion tactics, and we can also provide this to individual citizens so they can really they can change their behavior in order to reduce peak exposure and also associated health risks. And we can also conduct statistical analysis. This we show the important factors of PM2.5 exposure, and we can identify we can quantify the contribution of individual source to the PM2.5 exposure. This quantification is really important for health promotion tactics and also policy making. In summary, we demonstrate that the application of the advantage of these research-grade local sensors in PM2.5 health research. It is affordable to have multiple sets to monitor simultaneously for different locations and subject to enlarge sample size and representativeness. It is easier for us to recruit subjects since it is small, lightweight, without noise and vibration, and we can assess post-reality PM2.5 exposure and health impact. We also, based on the peak exposure and also based on activity, we can provide a precision prevention strategy to reduce their risks. Finally, I want to emphasize that in the post-COVID-19 era, we need to reach SDGs, so our local centers can provide benefit strategies to minimize pollution source, and so our society can benefit to reach these SDGs. In the end, I want to give an acknowledgement to all my research team and the funding agency. Thank you very much for your attention. Thank you.
Thank you so much, Dr. Long, for your interesting presentation, especially for shedding some light on the differences between individual exposure and what can actually be measured as from the monitoring station. But to me, this is especially a key point that may or may not prove the validity of some studies only using the monitoring stations. Okay, we have almost 20 minutes because we are right in time for Q&A. So please, the priority is given to students and our colleagues here. And please introduce yourself and ask your question. Thank you.
Yes, Utupan Longsin from Global Health and Health Security. I would like to ask for Professor YY. I'm interested in the national program to increase physical activity. So that I have two questions regarding to this program. The first question is what kinds of tool or information to identify that professor got the individual information from the same person since the beginning of the project. And because of correcting the individual information, and we also have the third party help of TPP, private public partnership in this. So how to handle with the data privacy? Thank you.
All right, thank you very much for the question. I think I mentioned the second question, but I need to repeat your first question. But let me answer your second question first on the public-private partnership. So there is actually a degree of data sharing, it's not a data confidentiality. So in terms of data sharing, what would be shared with the private industry would actually be information that the person signs with Apple. So for example, when they sign up to the use of Apple watches, and the Apple watch will capture some degree of information. This information is pumped straight back to the Health Promotion Board for analysis and for assessment. So because this information is tied to that specific individual, that individual must agree to allow Apple to access that information on that individual basis. But it's as an arrangement like what you have with your research study. Apple actually has to again commit to the individual as well as to the Singapore government that the data that they have is only used for the purpose of this study, that they can't even use it for their own commercial perspective, that it is used for the purpose of providing the incentives. Now then there's the second layer of data usage, which is by Health Promotion Board. Now Health Promotion Board actually, because it's part of the Ministry of Health, we actually have the ability to perform data linkages. And this data linkage means that I can link it with their health records. But we only permit such data linkages only in the context of policy setting. And when that linkage is performed, actually all identifiers are stripped off. So by the time the data comes to the Ministry of Health for even assessing on cost effectiveness and effectiveness, all they see is participant ID. They do not see any identifiers at all, and this information is never shared with the private industry as well. So that's why there is the study level information, which is or the program level information. Program level information is where individuals are identified, because that's where we need to send them the vouchers and incentives. But beyond that, actually, there are much more opportunity to make use of the data But that is never shared with the private sector anymore, it's never shared with the industry. But at the government level, they will use the data in an anonymized manner for policy and programmatic evaluation. Those are actually very important aspects in the use of digital approaches, because the evaluation actually guides, is this going to be worth the cost? And some of this evaluation will need to go beyond what the data is capturing. I talk about the linkage with actual healthcare data. This linkage is an important linkage, and that's always the most sensitive linkage, because people would say that, well, when I sign up to this, I actually didn't agree for my data to be used beyond the study to give me the vouchers. But from a government's perspective, they actually will use this in an anonymized manner to decide, is this national program fundamentally going to help the country save money? So that's on the question around privacy and the partnership between public and private. I'm afraid I didn't manage to get your first question. You talked something about same person, but maybe I could invite you to ask the question again.
Yes, Professor. What kinds of tool or information to identify that you got the information from the same person in the study, from the same person since the beginning of the project?
In Singapore, again, this is one of the nice things about the Singapore system. Everyone in Singapore, if you are a citizen, if you are a permanent resident, or if you are someone who has worked in Singapore, you are given a unique ID. And so for me to sign up to the National Step Challenge, they need to make use of my unique ID that I have in Singapore. Now, let me emphasize, this unique ID is tagged to me for my entire life, but when it goes for the assessment of evaluation, all this unique ID is changed to just a participant ID, like participant 0001. So that's where there's no identifier. With the unique ID, I can identify the person directly. So I have my own unique ID that in all my records, whether I pay taxes, my bank records, that unique ID stays with me for life, and it's tagged to me. So that's the way that someone who has been joining the National Step Challenge since the first year, I mentioned that now this is the 5th year. If someone has been joining since the first year, we would have the person's record for the past 5 years, which is a very powerful resource actually. And this is exactly the reason why we were able to understand what was the impact that the pandemic had on people's steps counts, because they would have already participated in the Steps Challenge 3, Steps Challenge 4, and Steps Challenge 5. So we have the data accumulated over the past 5-6 years. Thank you very much for your question.
Thank you so much, Professor.
Hello. Good afternoon. My question also, I'm Wing from the Global Health Program. My questions also go to the Professor Teo. We learned from your figures that there are two times of the lockdown. First time the circuit breaker, and then the second time lockdown as well. So we learned that immediately after the first time circuit breaker, the daily footstep counts still keep going low for several months. But in the second time lockdown, the footsteps goes up immediately. So one of the reasons could be that after second time, people don't care much about the COVID because they have some testing coverage already. Or the second possibility is that the database include not only the Singapore citizens, but also from the permanent residents, the special pass and the work pass coming from the Malaysian as well. So those effects could be because of the closures and then reopening of the Malay border. That means if we separate, analyze, then we can get a different figure for that full step, I think.
Thank you very much for your comment and question. So, unfortunately, the borders to Malaysia were not open at that point in time, because the second block was around April to July of 2021. So the borders, the causeway between, the links between Singapore and Malaysia were not open at that time yet. Now, but the reason why you're very sharp, because that's exactly the right observation, that in the first lockdown, it had a significant impact on the steps counts and people's physical activity, and even after the lockdown was lifted, physical activity remained low. But the second lockdown, it came down, but the moment the lockdown lifted, it went back up again. The reason was because the second lockdown coincided with the period where the season 5 of the National Step Challenge was already in place. So that was already the time where if you were physically active, you were getting incentives. And so people had a lot of financial incentives to actually keep them moving. And this was exactly what I meant about how during outbreaks or during crisis, people's behavior will change. But how do we maintain a health promotion effort to keep up the right kind of behavior? Monetary incentives can be a way. Of course, we always we like to think that we don't need to use money to incentivize people. But actually, the amount of money that we were giving people were not huge amounts. They were like $5 or $10. And to earn that $5, actually you need to exercise for about a month, making sure you hit about 10,000 steps for about 4 weeks consecutive, then you get $5. So to pay a person to take 10,000 steps for a month, and I pay them $5, you will realize that it's actually not a lot of money. But it's the gaming mindset that people have that, oh wow, the government, I have a chance to win $5 from the government, I won that $5. And that gaming mindset was actually what worked to get people to move, even during a pandemic. So you were right, during the lockdown it came down, but because it was in the middle of the season for the National Step Challenge, where incentives are given, that's where the moment the lockdown was stopped, people went back out to exercise. And the National Step Challenge lasts for a year. So we were collecting data throughout the year, but the incentive period were only about 4 to 5 months. So we only gave people monetary incentives for 4 to 5 months. The rest of the 6 to 7 months, there were no incentives given. Because precisely we want to see what happens when there's no incentive, the steps count will come down, then the new season starts again, people go back up. And we wanted to do this recurrently over a number of years, so that ultimately there's that mindset that hopefully there is going to be a permanent increase, even if the permanent increase is not that significant. We saw that the increase in the end was around 1,000 steps, and that was a good thing, much better than not having a national program. But thank you very much.
Okay, thank you. There's a question from Professor Jimba online. Please, Professor.
Thank you very much. This is a great chance for me to deeply think about digital dictatorship. And there are some comparatively country study to know the relationships between political system and COVID-19 control. And one of the tentative conclusions is that authoritarian political system is more effective to control COVID-19 compared with democratic political system. And this might be true. And my question is whether this is also true for NCD control. And if this is true, and a lot of NCD controlled by authoritarian political system, the government may favor to move from democratic to authoritarian political system. So this may be a threat to democracy. And this may be a very broad question, but I'd like to ask this question to Wayne first, and then Wai-Wai.
Thank you, Professor Jimba, for these excellent questions. And my quick reflection on the dictatorship versus democratic, I think it's a long game. As I think a few dictatorships have claim they have been more successful in combating the COVID, which has been proven not necessarily right, as we can see from the lockdown in Shanghai. And so it is a long game, but in terms of chronic diseases, NCDs and infectious diseases, I think there's so much less incentive for countries with authoritarian regimes to control NCDs, but NCD is more like a silent killer. It doesn't get a lot of attention. You know, sometimes it is even considered as the cost of when the society becomes more affluent, and more people get obesity and all these conditions. So my quick answer is, I believe that with the freedom of media and with the opposition's political spectrum, more diverse political spectrum, we are able to detect errors. The system is more able to adjust. Pretty much like we are adjusting to live with the virus. And when you don't have this democratic mechanism, you tend to either maintain survey's peace, or you might, when you make mistake, it could be a long-lasting disaster. So the only thing I can see is we will see.
Thanks, Wayne, for giving us and thanks, Jimba, for always very thought-provoking questions. I'll share my thoughts on with respect to what you've asked. I actually do not think that is the case for health promotion, because if we look at efforts against sugar as well as against tobacco, and very prominently we have countries like New Zealand, Finland, even Malaysia have already announced their intention to have smoke-free generation or tobacco-free generation, meaning that people who are born after a particular year will never be allowed access to tobacco or to spirits. And those countries that I named would be considered democratic countries. Similarly, if I now use the example of sugar, countries have taken a much harsher stance against sugar. Countries like the UK, they have sugar tax. There's quite a lot of health risk warning or front of pack labeling against sugar. So, including in France, there's also the use of their nutrient grade product labeling to warn people against fat, sodium, saturated fat, sodium and sugar. So you would see that this would be democratic countries that have taken quite strong stance against health promotion. And I think it comes back, when it comes to health promotion, which I actually believe is slightly separate from COVID-19, because COVID-19 there's a lot of enforcement issues involved as well. But when it comes to health promotion, it is about whether governments are taking a responsible stance, that they realize that at the heart of it, it is going to be extremely difficult to nudge behaviors of millions of people in the population. Whereas if I put in place a certain policy or a certain law that outlaws the use of trans fat, that outlaws the access to tobacco, that taxes heavily on the use of sugar, it will immediately affect the industry directly, and the cascading effect is that the consumers downstream may actually not realize that they have been deprived of some of this after a while. So the current batch of smokers will be the first one to reject the smoke-free generation. But because the smoke-free generation technically doesn't affect existing smokers, they will just be protesting on the basis of free choice. Everyone should have choice to do what they want. But that was exactly the argument that some countries have taken against drugs. That no, I deem this to be harmful enough, I need to take this away from you. So at the heart of it is really around how not just the policy setting, but also the communication that is necessary to the public to let them understand and justify why there is a need for a harsh stance, because it is much easier to do this as a policy level rather than to influence the behavior of millions of people to do the right thing, which we all know, even among public health practitioners, we don't eat our fruits and vegetables and exercise as much as we like. But that's my answer. Thanks very much, Jiva, for your question.
Okay, thank you. Actually, I do have a question for our first speaker. I hope it's not going to take too long for her to answer, for me to formulate. So, in your study, to me clearly shows that there is an issue when it comes to measure the exposure of to PM 2.5 when we don't have, as you did, personal equipment. So my question for you is, when this information is not available, when I cannot run an experiment like you do, how can I actually improve how can I say, experimental design aiming at quantifying the impact of air pollution at the population level? Because if I only use the monitoring station, it just show us that I may, or most likely may not, actually capture the true exposure. So what is your opinion about this, which I think is quite a hot topic in environmental health? Thank you.
It's a great question. Actually, people in PM 2.5 epidemiology has been using certain, like a land use regression model. If you want to do population type of epidemiology, in addition to using the monitoring station's data, you can consider what type of land use. That means what type of the source, emission source in that area. For example, if it is a heavy traffic area or street or boulevard with heavy traffic, and the people in the surrounding may have higher exposure. And if you live near some industrial area, so the pollution concentration may be higher. So they use this type of land use regression model to consider different pollution sources in different areas and give them weightings to monitoring data. So in this way, you can get better estimation for the human exposure compared to just simply only EPA monitoring data.
Thank you so much. Thank you so much for your answer. I think we can close here, session number 3, right in time. Thank you so much again to our 3 speakers, Dr. Kyo, Dr. Gao, and Dr. Long. And here in person, we will have a coffee break for 15 to 20 minutes, right? Okay. Thank you so much again. Thank you.
Thank you very much, Dr. Sana, for moderating.
The director in the PhD program in global health and health security. She earned her bachelor and master's degree from the law school of National Taiwan University. Also, she earned the public health degree from National Taiwan University. Also, the PhD in the occupational medicine and the industrial from National Taiwan University. Her research area is mainly in global health law,
可以吧？
infectious disease control, quality, and the health occupation health. Her topic today is the domestic the country's reported international health regulation 2005 capacity for infectious disease control during COVID-19 pandemic. The lessons from the previous pandemic activity. Let's welcome
Good afternoon, I think. It's my honor to have a talk regarding the topic today here. So actually, even though it's for infectious disease control, it's much more for talking about the policy issues in the global level. And might tackle a little bit the issues actually raised by previous section, like Professor Jimba mentioned about the issues of which a political environment is much more better for the disease control, or democratic, or another way. My topic is actually much more social perspective of the infectious disease issues. So let me share some of our ideas and some research findings. Here I don't think we have to go through the importance of pandemic in the human history. So actually it's long-standing in the human history. And so because of that, the infectious disease control is important. So actually in the very early decades, we already have international sanitary regulations under WHO and further renamed as international health regulations. The only thing is that because the public health technology advanced so much in the last century, so people forgot the threat and the pose of the infectious disease on human society. So the most focus of the public health field transferring to the chronic diseases rather than infectious diseases until the even though the globalization brought us the challenges, until the SARS pandemic in 2003, then the whole world again realized again the possible threat of infectious disease on the human society. So at that time, the whole world start to reconsider the global legal structures for infectious disease control. So International Health Regulation 2005 was amended in 2005. So it served as the major development in the use of international law for public health purpose. And it served as the foundations for the global policy for infectious disease control. So today I only wanted to talk about one requirement and one obligation set it up in the regulations. That is the create obligations of members to develop minimum core surveillance and response capacities. So I think every country originally or fundamentally have this kind of preparedness. So almost every country have CDCs and also develop their own surveillance and response capacities from the very beginnings. But after SARS, there is a requirement for countries to recognize and also to aware of the importance of the improvement of their core capacities. So with this, with this obligation set it up in the ICHAR 2005, the WHO Secretariat further developed a minimum core capacity evaluation tool. So going through the self-evaluation approaches, this obligation requires countries to report their self-assessment outcomes regarding their core capacities for infectious diseases every year. So this tool is generally released in 2010. So it's already 10 years before. So within it, it covers 8 core capacities and a point of entry and 4 hazards. However, even though there is a requirement there, the enforcement or the response rate is quite low. So you can see that in 2012 and 14, the response rate is low. And then during those kind of years, the Ebola is globally mainly happened there in Africa and caused a lot of deaths and health losses. So in 2016, the Review Committee of Asia actually recommending to transform the approaches from self-assessment to external evaluations. So with that recommendations, currently WHO also introduced the external evaluation approaches for countries to understand more about their own core capacities regarding infectious diseases control. So like now everywhere, for example in the hospital or in the university levels, we have a self-monitoring self-evaluation, but also we also have the external evaluation in order to enhance the understanding of the real situations of the units. But one of our studies collaborating with Georgetown universities found out that this is the information regarding the comparison between the similar scores for the same capacities from self-evaluation and from external evaluations. And you can see that the green line is actually the scores from external evaluations. And the red and blue is from the self-evaluation. What does that mean? It means often countries were scoring themselves a little bit higher than external evaluations. And it's not surprising, right? So we often have those kind of experience. Even though the reality is like that, but even on looking in the mirror, we see different us. We see a better us. So it's so-called somehow self-report bias. And so, but however, it's not on purpose. It's not from a negative attitudes regarding this cheating of this kind of scores. Rather, it's a little bit this is some bias from looking yourself from your own view eyes. So there could be a possibility of this for the explanations of previous findings. So and then that leads us to think about why this gap happens. Why the external evaluation is much more significantly lower than the self-evaluation. The explanation could be possibly two possibilities. One is on purpose by self-cheating, but the others is another reason. So, but more importantly, as international approaches for increasing countries' capacities, we wonder if the self-reporting approach is useful or not. Because if it's not useful, then it's not worth cost so many times and efforts of the countries to invest in that areas. So we conduct a study, and this study is actually conducted by me and also the next speakers from the Mahidol University, Thailand. We conduct a study to answer the questions: if IHR self-reported scores meaningful, useful, and should be continued to use. And then luckily that from our studies, it shows that yes, the countries with better self-reported scores perform better in the infectious disease control outcomes. So from that perspective, yes, it's still useful. Although some countries actually unrationally score themselves 100, which means they think their performance is perfect. So, but at least that self-report approaches is useful at that point. But then that leads us to think about then why there's so much gap, so big a gap. between the self-external evaluation. At that time, we wondered maybe because the country's transparency, which means more democratic countries might have bigger gates or less gates because there is a population monitoring. But when we are wondering that issue, here comes the COVID-19. And here COVID-19 actually changes a lot of things. But one of the most interesting things in this field is that this is a paper published on Lancet in the very early stage of COVID-19. And this is published by the virtual teams who is evaluating the self-report scores. And then their conclusion is that from the reported scores of each country, the most of the countries around the world should be capable for responding to COVID-19. And that's their predictions. But everybody knows what happens, right? Even without study, you know that the control outcome in the first year not matches with their scores, right? If we use case numbers or death numbers as an indicator for COVID-19 control outcome, then countries openly in the high income countries openly most severely hit by COVID-19. So yeah, we still conduct a study to check if the IHS score is matched with their COVID-19 control outcome. Then the study result shows that yes, openly the countries with higher scores will delay a little bit the spread of the COVID-19 virus in the communities. However, the final confirmed cases numbers or the death rates or death numbers might not be totally matched with their IHS scores. Okay, then again, back to our original question. Then is this self-evaluation approach still useful? If it's actually not predicting the outcomes, then is that still useful? But then one of the important points is that this tool is actually set up for help countries to understand themselves better and then to trying to find a way to improve themselves rather than for the country comparisons for the others with the others. So with that understanding, we go further. I think this is crucial because also even in this moment, the whole world is discussing now, do we need a new pandemic treaty or actually reverse the IHS no? And if, no matter which way, the point is what kind of existing mechanism is worse, continue, and is what kind of new mechanism should be considered in the future. So we try to conduct a study to compare the scores before the COVID-19 and after the COVID-19 to see how countries evaluate themselves during this pandemic. So that's our findings for the countries around the world. So you can see that the COVID-19, I don't know what's your conclusion in the very beginning. In the very beginning, we assume the scores will be decreased since the COVID-19 actually severely hit and everybody suffered. But actually, a little bit out of our surprise that actually in average, the whole world, their IHR scores actually increased. So that's interesting. But if we go into the details, actually 56 countries, their scores is actually decreased. And those countries is mainly from high-income countries, which means that high-income countries actually consciously understand about their weakness in the infectious disease control capacity. So those 56 countries, their scores actually significantly reduced after 2019, after 2020, which means after COVID-19, they reduced their scores. And for the other 98 countries, their scores significantly increased, and those are mainly from middle and low-income countries. And we guess that's because due to the heat of COVID-19, most of them receive more grants for infectious disease control. but they are further, have to be understood by other studies. But at least we realize that, okay, this tool is still useful, that since countries will consciously evaluating them and then trying to find the weakness of themselves to improve further, then we can go, we think this tool is still useful, but it's not sufficient enough. It needs more modifications. And another idea is that maybe one of the things of this finding is that the current tool is letting off the concern of the social value for infectious diseases. For example, during COVID-19, yes, of course, everybody concerned the health status. But even more, we think about not only economical situations, but also we are wondering the values of the freedoms of movement, or we are considering the value of social connections and so on. Which means, even during the infectious disease control, what we should consider is not only the value of health, but also the values of other social needs. So with that ideas, we actually echoing the ideas of the resilience capacities raised by the Bloomberg. So within their resilience capacity, there are three items here: reopening, COVID-19 status, and quality of life. And we agree with those kind of concepts because living as a human being, even during the COVID-19, even during the pandemic, those are the needs and also the values of the peoples. So especially for us, I think the quality of life shows the most of what's the real need of the peoples living in the societies. So, but we slightly modifying a little bit the items or the index used in the resilience capacities to form our own resilience capacities, and then trying to match with the IHS scores. The idea is that we think the quality of life would be the most significantly associated factors with IHS, rather than only COVID-19 status, which representing only the concern of the health indicators. And our preliminary analysis also shows that, yes, the quality of life is the only items which is significantly associated with the IHR rather than the COVID-19 control indicators. And so I think these studies shows also that social value matters even in infectious disease control policies. And also the world should continue to use this factual approach, but there should be some modification and ideal thinkings regarding what should be covered within this kind of so-called capacities. Okay, so this is my talk. Thank you.
Thank you very much for Professor Chai's very excellent lecture. According to the timetable, we will keep the question and we have general discussion. Now we will move to the second speaker. The second speaker is Professor Masros Kitaya from the Mahito University, Thailand. Professor Masros is alumni of Taipei Medical University. Actually, she earned her PhD degree in epidemiology, not TMU, from National Taiwan University, and also she holds the public health administration bachelor degree as well as Master of Public Health from Mahito University. And her field of expertise is infectious epidemiology, occupation epidemiology, applied epidemiology in public health policy, and social determinants of health research. Now she is also the chair of Master of Public Health program in Mahito University. Her topic of presentation will be international epidemic control grade 9. A lesson learned from COVID-19. Let's welcome Professor.
Thank you so very much for the introduction, and I just also would like to thank the organizer for giving me this opportunity. Today, my presentation will focus on how can we make the COVID-19 epidemic control effective. I will present to you my simple analysis from the situation of COVID-19 epidemic in Thailand, and also from some documentary review. My presentation will be the simplest presentation of today's presentation. So, all of you know what the COVID-19 is, so I don't have to explain more about it. But I just would like you to see the timeline of it a little. So from the beginning of COVID-19 at the end of 2019, it just took around 3 months to get across the globe from Asian country into the Western countries. And collectively, if you're looking at the situation of COVID-19 throughout the world, this is the update information in April 25, 2020. You can see that throughout the globe, COVID-19, like already occupied every country in this globe already experienced the COVID-19. So if you're looking at the evidence of COVID-19, I think the first speaker already mentioned about the international health regulation. We're looking at the national standard, the national population in South Africa. But in my analysis, it's likely focus into like the internal process within the country, what happened. So when we talk about epidemic control of COVID-19, also you know quite a lot about the cycle of the response. We are monitor throughout our solar system, and throughout the solar system we can detect any unusual happen, and then we can assess whether that unusual is need any response. And then we report to the focal center like the CDC and the first presenter talk about that. And even in Thailand, we do have our Department of Disease Control that also takes responsibility for this kind of thing. And after that, after the report, after reporting the situation, the response of COVID-19 or any type of epidemic will respond to control and prevent the next epidemic that might happen. And throughout the cycle of this country, like after the cycle of epidemic control, those images and images to this thing quite well. The situation of COVID-19 back, let me give you some brief overview. The situation of COVID-19 in Bangkok, we are, I'm not wrong, but I just would like to mention like that. We are the first country that reported the COVID-19 out of China in the beginning of 2020. And after that, like almost the end of the 2020, we faced with the second wave of our COVID-19, like about 3,000 cases has been reported to the government. And you can see that in the second wave of our, in the first wave and second wave of our COVID-19 pandemic, we can control it quite well. And after that, to the third wave, fourth wave, and fifth wave, it seems like what happened, why our cycle, our infrastructure, our system is collapsed. So that's why this situation happened. I just would like to say that the thing changed due to the situation, and I would like to share with you throughout our economic analysis. According to the epidemic control of COVID-19, I analyzed our situation of practice together with some documentary reviews. And we found that there are 3 approaches that have been implemented in our country. The first one, I use the term coordination, three C's approaches. Coordination, communication, and competence. Why in Thailand we put three approaches? Let me give you more detail. For the first C, cooperation. When we talk about cooperation, I think almost every country is the same. But I think COVID-19 in Thailand has come. These events provoke like a very strong cooperation between the government themselves and also the society. So we applied a so-called whole of government approach and also the whole of society approach. The thing that we found that by the whole of government approach, we gathered all information and all organizations and institutions that take responsibility for the whole country, like the Ministry of Public Health, Ministry of Finance, Ministry of Interior, and also Ministry of Foreign Affairs. Sit together as the CCSA, that means the Center for COVID-19 Situation Administration. And this center takes responsibility for the COVID-19 crisis in Thailand so that attack the first wave and the second wave of COVID-19 very effectively. And the second point, we apply a whole of society approach. And based on my knowledge and also observation, we found that the whole of society approach during this COVID-19 is just like a very strong cooperation. Not only the public and private, but also civil society, they join hands together to fight against COVID-19. In the first and second wave of COVID-19, we are facing with some overwhelming of COVID-19 cases go through the hospital, and that made the health system, how to say, overwhelming with the case, and we cannot handle the case alone. So the private come to join us by work together with the Ministry of Public Health. For example, as you see on the left-hand side picture, it's just the warehouse of manufacturing and exhibition of some, how to say, portal or some exhibition center turned to be the field of hospital that can take responsibility for those mild symptom cases, go to and then we can reduce the burden from the hospital. But not just only those factories, but also in the hospital. Like the hospital and those tourist industry. They make collaboration between hospital and hotel to set up a specialized ward. So in Thailand we call it hospital. And this type of thing can reduce the burden of the organization and also from hospital as well. The second thing, communication. First of all, I have to talk about this risk communication system that I took from the presentation by Dr. Su. I would say that the risk communication is very important during the crisis. And based on the media and communication theory, we do know that whenever crisis happens, those information should come from only one source. It's not just like come from other sources. Otherwise, people will confused and don't know what to do and what to act. In the first period of our COVID-19 pandemic, I would say, it is a very incredible risk communication in Thailand. Because the CCSA take a responsibility as the source of information. They gather all information from other institutions and stakeholders, and then disseminate the information to those media, general public. It just comes from the single source. And that may cause the effective compliance among the population. So that in the first wave of us, all people just waiting for what going to be the next information and what we should we do. How? After the second wave and the third wave, the information is overwhelmed from other countries or from other sources. We have not wait in have not been waiting for the information from the citizen at all. Because many types of media throughout the country, not just only internal media, but also those external media from the other country, also have an overwhelming information back to people in China. And those type, and that may comprise of misinformation and disinformation. This type of media communication and information may cause the misperception of the population. And then we can see that type of those misperceptions can reduce the compliance among the population, in particular the social media, and also make them feel hesitant to take vaccine. This is just like a simple example of those informative that we are facing. If we're talking about the environment, I would say it might be because we are under the technology disruption. Everyone believes that the information can cross the world within 1 minute or 1 second. And yes, of course, I myself obey and comply with the government information, but I just heard that learned that other countries, they don't think this is a good measure to do. So this type of thing cause, like I just mentioned, misperception and compromise some public and also public health and also the social measure very much. If you would like to understand whether how important economy is, we can see from the number of applications in the public during the year 2021 to 2022. It's around like the increasing sharply. That means economy become our central of attention. What I would like to say that once we are under the disruption of technology, I think it's very important to have the central platform to manage those type of environments. For example, we have to update our information very quickly. I do remember that Taiwan also did quite well at the beginning of information, at the beginning of pandemic. So we can gather those new information from the new knowledge, and then we translate it into a very simple information that our general population can understand. And also in the same time, we have to have those fact checkers. Like in Thailand right now, we do have COFAC. In US, they do have fact checking to identify those misinformation and disinformation. And the third sphere of mind is community. Why community approach is very important, community-based approach is very important for those disease control. Let me give you an overview of infrastructure of Thailand administrative district. Because Thailand, we have four level of administrative district. We do have province, district, sub-district, and villages. And because of this, according to this administrative district, the capacity of our government performance that we try to embed our infrastructure, those also delivery throughout the level of our administrative district. Last, a very important part is we do have this very, thankful to our Department of Disease Control that they produce about like 1,000 SRT team is the surveillance and rapid response team at the district level through the village to the provincial level. But what about in the village level? What do we have? Actually, we have a very moving surveillance system. That is our village health volunteer that we can embed, that we can enhance their capability and to make it like the community-based approach. Let me give you my viewpoint on the community level practical action. As I just mentioned to you that in Thailand, we do have a very nice infrastructure from the provincial level to the village level. And our village health volunteer, just one village health volunteer may take responsibility for only 10 households, and maybe about 50 households in some area. So this is a very good model for us if we would like to detect any type of unusual situation. So we can apply this thing.
The point is our public health infrastructure is domestic. So how, if you try to make collaboration at the provincial level, district level, they will have so many stakeholders to involve that may make our how to say process or movement a bit slow. But if we can strengthen our community network excellence system by using our moving solar system, it might be another story that we can discuss and moving further, moving forward. What I mean by the moving solar system, I think the first thing is about the engagement. If we can identify the criteria, such as simple criteria, easily to our property base, and then we can detect such according to that criteria, and then we can report to the SRT team or the person who takes responsibility at each level of the infrastructure. And those SRT team or those health service facility that take responsibility to take, they can verify and make a response. Last but not least, the corporation and those community members in the village level are very strong. So the main challenge up to now from the lesson that we learned from the COVID-19 is, because when we make decisions, try to implement any type of public health measure or social measure, we do need the data. But in Thailand, because our data just a very fragmented, and we found that this might be a next step that we can do if we can combine the data properly, and we can have the national, or we use the term the central, the data central, that we can use those things for that Professor Dale was just mentioning, the national issue. And the second challenge is about the cross-border control, because Thailand is have a geographic challenges. We surrounded with our neighbor, Myanmar, Laos, Cambodia, and Malaysia. And people can just walk across the border easily. And that may, how to say, detection, our ability to detect any type of disease may be low, that will be compromised. And the second point about the race trafficking, honestly, I think everyone knows about that. Many of immigrant workers, those undocumented, can cross the border all the time. That may be another issue that we have to think about what we can do for international cooperation. I think that's also my presentation. I finished my talk a bit earlier than the time has set. Anyway, thank you so much.
Thank you so much, Professor Nasros, for sharing the many valuable lessons from Thailand. In Thailand, we really share many similar challenges, and we share similar strategic measures as we took in Thailand. So thank you again. Then we will move to the third speaker, Dr. Wu Aoxin, who is a medical doctor, a medical officer in the Center of Infection Control and Biosafety in Taiwan Centers for Disease Control. Dr. Wu has both clinical experience as well as public health experience in his career development. He earned his medical doctor degree from Taiwan Zhongshan Medical University. He also got the master in the master degree in Graduate Institute of Injury Prevention and Control in Taipei Medical University. Dr. Wu's presentation today will be the analysis and the responses of healthcare-associated COVID-19 outbreaks in Taiwan. Ladies and gentlemen, please join me to welcome Dr. Wu.
孤单的感觉。
My pleasure here have a presentation, and my topic is the analysis and the responses of healthcare-associated COVID-19 outbreaks in Taiwan. During the COVID pandemic, the healthcare-associated infection of SARS-CoV-2 has emerged as a significant concern because the hospitalized patients are usually vulnerable to healthcare-associated COVID-19. In a multi-center retrospective observational study conducted in UK, the mortality of COVID-19 inpatients was higher in the cases with healthcare-associated infection than those infected within the community, with the risk of 1.23. In addition, the already overflowing medical capacity due to the surge of the epidemic would be more restrained due to the healthcare-associated infection and the infection prevention control measures to contain the outbreaks. For example, the healthcare worker might have sick leave due to get infected or be quarantined due to exposure. Moreover, the medical facilities with outbreak occurred might have to lower their operations to maintain the outbreaks. The restrained medical capacity will contribute to the excess mortality due to the delayed or inappropriate treatment for the other critical medical conditions. The mode of COVID-19 transmission in hospitals involve the patients, the visitors, and the healthcare workers in a multi-directional way, such as the visitors to patients, the healthcare workers to patients, patients to patients, and the workers to workers, etc. Considering the more interaction of the healthcare workers and the visitors with the community, they are more likely to introduce infection into hospitals. Currently, there is no universally effective definition of healthcare-associated COVID-19 due to the possibility of asymptomatic or subclinical infection and the long incubation period up to 40 days. Different countries or organizations use different definitions of the hospitalization day to define a healthcare-associated COVID-19, ranging from 5 days to 14 days. And the 48 hours after admission is a commonly used operational definition for the traditional surveillance for healthcare-associated infection. It is more sensitive, conservative, while consequently more likely to overestimate the true incidence of healthcare-associated infection. There are several studies about the epidemiology of healthcare-associated COVID-19 in the early pandemic. From China's reports, the prevalence of healthcare-associated COVID-19 were as high as 40%. The Italian data show that infected healthcare workers accounted for about 11% of all confirmed cases. In the UK cohort study, about 10% of the COVID-19 inpatients were diagnosed 7 days after their admission, which implies the possibility of healthcare-associated transmission. A national cohort study conducted in Germany during March 2020 to September 2021. We show that about 1% of the COVID-19 cases in Germany were related to a healthcare-associated outbreak. In Taiwan, the first wave of community epidemic occurred during May to July 2021, and the second wave started in March 2022, which is still ongoing right now. Till this week, there are more than 150,000 domestic cases since the beginning of the pandemic in Taiwan. Nevertheless, the information of the healthcare-associated outbreaks in Taiwan is lacking. Of course, we cannot afford to analyze the nosocomial outbreaks during the current surge of the pandemic. Therefore, we use the investigation report from the Public Health Department during the first wave of community epidemic in the last year. We use this investigation report to conduct a national cohort study we aim to describe the knowledge of healthcare-associated community outbreaks in Taiwan and to compare the characteristics of infected healthcare workers, patients, and their companions in these outbreaks. The study period is during the January 15, 2020 to July 1st, 2021. COVID-19 has been designated as a notifiable infectious disease in Taiwan in the early 2020. Therefore, a healthcare worker is obligated to report a patient who meets the reporting criteria to public health department. And then the public health department will to conduct the case investigation and the contact management. Nevertheless, the investigation during the current surge of the epidemic is hard to conduct. In our study, we didn't use an arbitrary hospitalization date to define a healthcare-associated infection. Instead, we ignored all outbreak events which were recognized as healthcare-associated by the public health department in their investigation report. The primary case is deemed a case who is suspected to initiate a chain of the healthcare-associated transmission, while the secondary case is deemed as a case who was involved with the epidemic in the same outbreak with the primary case. The outbreak duration is the period between the dates of the first positive RT-PCR to the primary case and of the last confirmed case in the same outbreak. During the study period, there were 54 healthcare-associated outbreaks of COVID-19 dispersed in 26 hospitals, affecting about 512 cases, accounting for around 3% of the national domestic cases during the same period. The outbreaks shown in the orange bar, we can see it peaks alongside with the sharply rising trend of the community epidemic. And we categorize the outbreaks into three groups according to the identity of the primary case, the healthcare worker, the companion, and the patient cases. The outbreak with a patient at their primary case were associated with a more confirmed case and a longer duration of the outbreak persistence, although without significant statistical significance. While the outbreak with the worker at their primary case was significantly associated with a higher proportion of secondary cases as a healthcare worker. One of our hypotheses for this difference is that while the healthcare worker will use appropriate personal protective equipment when they're caring for the confirmed case, and they might take off the equipment when doing other non-medical activities, such as dining their colleagues. Such exposures are more similar to the daily activity in the household with the household members, and which might facilitate the transmission of virus among the healthcare workers. Among the 5,012 cases, about 40% are companions and 40% were patient cases. The 8 and the 30-day-old mortality were higher in patient cases, while the proportion of female was higher in the healthcare workers and the companion cases, which is comparable with our impression that more females take up the responsibility to care patients and the family members. The overall COVID-19 vaccination rate is quite low, and only 6% of the total cases have been partially or totally vaccinated. It is probably because the national vaccination campaign was just rolled out at the beginning of the community epidemic. This table shows the multiple variable analysis for a 30-day-old course mortality. And you can see the 30-day-old course mortality was significantly associated with the patient cases. The case is age equal to or more than 65 years old, and the female gender. The Kaplan plot shown here also demonstrates the result of the 30-day all-cause mortality analysis. And the upper one is classified cases by the identity, and the below one classified by the age. And we can see the patient cases has a higher 30-day all-cause mortality with a hazard ratio of 50. And the cases with age equal to or more than 80 years old also has a higher mortality with a hazard ratio of 3.9. To help the medical facilities to respond to the healthcare-associated outbreaks, the Central Epidemic Command Center has established the relevant guidance. Require hospitals with outbreaks occurred to organize an outbreak response team to manage the outbreak and to conduct contact tracing and quarantine of the close contacts, to expand the testing and enhance the surveillance for the people with the risk of infection, and to reinforce the environmental cleaning and disinfection, and to close the units of where the outbreak occurred is indicated. In addition, the Central Epidemic Command Center also implemented several non-pharmaceutical interventions to prevent the healthcare-associated COVID-19. In the early epidemic, the universal masking, symptom surveillance, and the visitor restriction, and the establishment of designated ward for carrying company cases has been implemented in early epidemic. The national vaccination campaign has been rolled out in March 2021. And during the first wave of community epidemic, the universal testing for newly admitted patients and their companions, periodic testing healthcare workers were implemented to early identify infected cases, considering the possibility of asymptomatic and pre-symptomatic infectivity. Although the previous mentioned measures might help Taiwan go through the first wave of a community epidemic, it might be a different story when we encounter the Omicron variant of concern. Due to the high transmissibility of Omicron variant, the hospitalized patients increase remarkably, and the staffing shortages in medical system and the public health are even worsened due to all kinds of scenarios and normal situation. Therefore, much of the prevention measures aforementioned are hard to conduct due to the staffing shortage, such as contact tracing, closing of close contact, or the closure of the units where outbreak occurred. Besides the no less, maintaining the appropriate staffing is critical to providing a safe work environment for healthcare workers and a safe patient care. Therefore, we have in mind several measures, such as shortening the quarantine period or even waiving the quarantine period for the healthcare workers when they are exposed. This is my last slide to wrap up. The intention is still the most vulnerable group to the healthcare associated COVID-19 outbreak, especially the eldest age equal to or older than 80 years old. Second,看状况吧，看他怎么办，也不能说买了不用，因为100多万，也是会被检讨。About 40% of the healthcare-associated COVID-19 in Taiwan should be addressed in infection prevention and control measures. Third, the healthcare worker to healthcare worker transmission can be a potential amplifying factor in healthcare-associated COVID-19 outbreaks, which is probably due to the inappropriate use of personal protective equipment during the interactions among the staff members in hospitals.
没有，你可以直接跟，你可以直接跟外部联络。没有问题啊，因为毕竟不然就跟局方吧，就数位资源。
To provide a safe healthcare worker environment and safe patient care. And thank you for your attention.
Okay, thank you, Dr. Wu, for your very
看
informative
他，
presentation regarding the outbreak of healthcare
对啊，
associated
看他，
infection of COVID-19 in Taiwan. You also propose many helpful measures for coping with potential
有可能就是，
health
对啊，
professional workforce
他
from
是现场，
in hospital
他改现场。
infection. So we will move to the
没有没有，
topic
我在弄
presented
case。
by Professor Jiang Zhenyuan, who is my colleague in Taipei Medical University, Wanfang Medical Center.
好。
Professor Jiang Zhenyuan
好，拜拜。
graduated from the Taiwan Kaohsiung Medical University and he got the master degree in public health from the School of Public Health in the UC Berkeley, and he also earned the PhD degree from the University of Bergen, Norway. Professor Jiang does have a wide range of job experience, and just some of many important one is the consultant for Department of Scientific Activities, International Union Against Tuberculosis and Lung Diseases, and Director, Department of Lung Health, the Union Paris. Then the core group, the Global Drug Resistant Tuberculosis Initiative, and his current affiliation including the Department of Internal Medicine and the Senior Consultant Department of Tuberculosis, the Union Paris, and also associated editor in International Journal of Tuberculosis and Lung Disease, also the associate editor in Public Health Action. So let's welcome Professor Jiang to talk on the impact of COVID-19 on the prevention and the treatment of tuberculosis and its countermeasures. Ladies and gentlemen, please join me to welcome Professor Jiang.
Thank you, Chairperson, for your kind introduction. I'd like to thank the conference organizers to invite me to make these presentations about the impact of COVID-19 on tuberculosis and also the countermeasures that is needed to address the impact of COVID-19. So from here we can see that the number of patients infected with SARS-CoV-2 globally is mounting. Up to now, there's already 514 million persons being infected and more than 4 million people died of this COVID-19. And basically, every country got affected. You see that in Africa, the small tiny dots perhaps reflect less infection, but also possible underreporting of infection in Africa. In early 2020s, the impact of COVID-19 on TB has been estimated by the sub-TB partnerships. You can see here, basically the 2 months lockdown and 2 months restoration may cause increase of incidence and also mortality of tuberculosis as shown by the red line compared with the status quo, the blue line. And then the prolonged lockdown and restoration would exacerbate the impact on incidence and also mortality of tuberculosis. And a similar exercise has also been, this is provides some detail of this estimate that you see that globally, 2 months lockdown and 2 months recovery in early 2020s may result in a 3.1% increase of the excess cases of TB and then 4% increase of mortality. And with the extension of the lockdown to 3 months and 10 months recovery, we expect that there may be 10% increase of excess cases and then 16% increase of mortality of tuberculosis. And similar exercise also been done by World Health Organization. For my friend in Brazil, he used the different scale of case detection, reduction of case detection to estimate impact, and he showed that 25% average 25% reduction over 3 months may bring us back to the mortality status back to 2015. In fact, that's quite a substantial drawback on the global TB prevention and care. And the actual situation is being shown by the Global TB Report 2021. You see here, compared with 2019, almost across all the individual regions, you see the major reduction of the number of cases being detected in all over the regions. And a little detail is here. You will see that the 16% 16 countries with the largest contribution to the global shortfall reduction of TB notification in 2020 compared with 2019. The top three will be India, Indonesia, Philippines, followed by China and Bangladesh. With this decrease of case detections, those cases not detected yet, you expect that the mortality would increase quickly. So here is the global estimate about the increase of mortality, both the number and the rate, the mortality rate. You see that a little bit upward in 2020. A little bit into the detail of different countries, you see that the extension of the estimate up to 2025. You see the number of people, the mortality would increase substantially in 2021 and 2022, and then decrease after that. But you will see that up to 2025, the mortality may not be back to the situations without COVID pandemic. And the impact of COVID-19 on TB instance would be slightly delayed. On mortality will comes first, because the reduce of the case detections will result in the increase of people die from tuberculosis. But then the transmissions may also cause the increase of cases, so that will result in the increase of incidence of tuberculosis. And you see that in 2020, the increase of incidence may not be seen, but then afterward, you see different countries. You see the Brunei show you the increase of the incidence in different countries. That not only tuberculosis, but also the difficult cases of tuberculosis, that is cases with a drug-resistant tuberculosis. You see that overall, globally, this is the number of cases detected, and then you see that in 2020, you got a decrease of the number of cases being detected. So expectedly that, in 2018, there's a United Nations high-level meetings on global actions against tuberculosis, and also set target of TB cases and to be treated, and drug-resistant tuberculosis to be treated, as well as those number of people provided with a preventive therapy, and set a target. Here you can see that there's a big for the cases to be treated, is only 50% being reached, but then for the drug-resistant tuberculosis, you see that only 32% of the target being met, and then in children only 11%. In terms of preventive therapy, you see that there's quite a big range of the gap in reaching the target. Only 29% are being reached by all ages for preventive therapy. And among also living with HIV, that has a better job being done among those being infected with HIV. But then for children, you still a lot of things to do in terms of the preventive therapy. So in 2020s, I'm a advisor of the World Health Organization in the Western Pacific. So we quickly come together for a few meetings and also organize the meetings. Of course, it's the vital meetings for the national TB programs in all the Western regions to discuss the impact of COVID-19 and the restoration of tuberculosis services in the Western Pacific region. So I quickly put together those material and then submitted for publications on that article we published on the European Respiratory Journal. In the meetings, we discussed that the countries, the impact, what happened to the countries. And so if we begin with China, you can see that China has cancellation of public transportations, prohibition of public gathering, requirement of citizens, that they stay at home during the lockdown period. And then they have a survey and showing that the restriction of travel and traffic that result in barriers for patients to access care, and also difficulty to trace presumptive cases that require examination, difficulty in student transportation, difficulty in ensure patients can really get the medications taken, and also challenges for contact tracing. So the actions that have been taken in China include online diagnosis and prescription of medications, and also set up independent TV ward and electronic means of treatment support. Otherwise, difficulty to ensure that patients are taking the medicine, and health education to mitigate the panic of the public on COVID-19, as well as procedures for dual testing of COVID-19 and tuberculosis. In Malaysia also, they have border control, they have restriction of movement, they have social distancing and self-protection through personal protective equipment to flatten the COVID-19 incidence curve, and then you would expect that there will be reduction of case findings also in Malaysia. What they have done is that they have the online class lane appointment for clinical visits. They have TB screening also among COVID-19 cases, dual screening, the drive-through and drop bar for sputum collection so that they can detect tuberculosis, enhancing mobile X-ray tool to overcome overcrowding in healthcare facilities, and also treatment support being changes from the facility-based to community-based in order to reduce the patients going to healthcare facility. In the Philippines, also they have a community quarantine, and the active TB case finding was discontinued, and those individuals with the symptoms, they go to health facility also restricted. They're afraid of being infected with COVID in the facility. Priority of health services being shifted to COVID-19. So the machine, that there was a machine we call Gene Expert, that platform could be used for testing of SARS-CoV-2, also been reassigned for COVID-19 screening, and consequently the examination using Gene Expert for TB will be reduced. And then you can see that the immediate decrease of almost 8% in TB notifications in the Philippines. In response, they developed an NTP adaptive plan for during the COVID-19 pandemic period. And together that all the NTP managers and all the consultants together, we discuss what needs to be done in order to have restoration of the TB care and prevention in the region of the Western Pacific. So there are three key areas that we discussed that are really important to come up with innovation, innovative interventions. For case finding, that has been affected most heavily by COVID-19 because of restriction of the travels. People cannot present themselves when even they have symptoms, they stay at home, they cannot go. So what is important would be to increase case finding through development of new standards of clinical consultation, the establishment of affordable online consultations for individuals with presumptive tuberculosis. It's also important to strengthen sputum transportation because a sputum exam being done in different facilities, and not all facilities has the capacity of doing sputum examination. It's also important to come up with an algorithm for dual testing for TB and COVID-19, and then apply the digital platform and connectivity solutions to quickly inform people the result of testing, and also strengthening the contact innovation through during the community quarantine. That will be important activities for strengthening case finding of TB during the COVID pandemic. And then comes to treatments, it's also important to ensure that those who diagnosed with tuberculosis still can take drugs regularly without interruption of their treatment. So we believe that innovative approach for enrollment will be important. Otherwise, those who test positive, they may not be treated. We call them initial defaulter or initial loss to follow-up. And then, taking medications of TB is not an easy job. It's a prolonged duration of treatments up to 6 months for susceptible TB, and could be up to 20 months for patients with multi-drug-resistant tuberculosis. So it's important to ensure that the services will be provided to the patients without interruption. And then treatment support providing to patients will be important because the duration of treatment is so long, and then also come frequently with adverse reactions. So we need to come up with some digital adherence interventions, like video DOT, contact your patients on a daily basis to ensure that they take medications without trouble, and send short messages to remind them to take medications, as well as innovative use of mobile applications for that to make the job done. And as I mentioned, that the adverse reaction was quite common, especially of patients who were taking medication for drug-resistant tuberculosis. So we need to have some digital mechanisms for the management of patients who suffer from adverse reaction due to treatment.
And then obviously to get the job done, we need resource. Without resources, we cannot really make it happen. So we think that it's important to have multi-sectorial approaches for the restoration and enhancement with the enhancement of budget and also human resource for TB prevention and care. It's also important to mobilize community healthcare workers and civil society organizations and community-based organizations to strengthen response to both TB and COVID-19. And lastly, it will be innovative approach for training. Without training, people do not know. There's new developments in terms of diagnosis and also regimens, being come up even if during this COVID-19 period. So we need to train healthcare workers and also provide health educations of the community on TB and COVID-19 through mainly digital platform. And obviously, what those activities are clearly important, but the most important, in fact, is to quickly stop the pandemic of COVID-19. But what is needed, in fact, is high vaccine coverage is essential for rapidly ending the COVID-19 pandemic, which is critical for the rebuilding TB services and then other essential health services. But you can see that from here, you can see that I just take the data from WHO dashboard. You can see that the proportion of people who got vaccinated was substantial in high-income countries, but you can see that in low-income countries, it's quite low. The proportion of people who got vaccinated is quite low. So, and the group of 20 leaders, the meetings in Rome, in Italy in 2021 has committed themselves to ensure that 70% of the global population will be vaccinated by mid-2020. But whether that can really could happen, that will remain to be seen. And we also discussed that during the COVID-19, we need to have a regional framework for tuberculosis prevention and care in our region, in Western Pacific. So we have our almost monthly meetings to develop the regional framework to end TB from 2021 to 2030s. And in the discussions, we believe that during the COVID-19, there were opportunities provided from the experience of the COVID-19 for global tuberculosis prevention and care, especially in our region. So we see that there are opportunities to also strengthen TB prevention through integration of multi-sectorial approach, people-centered outpatient and community-based care. Digital health innovation obviously is important during the period that people cannot really travel and cannot meet each other. And then proactive planning, procurement, supply, and risk management will be essential. And we can so many things that we can learn from the COVID-19 pandemic, even including the development of vaccinations, also the drugs and all the new, quick, data sharing. Those are important lessons that we can learn from COVID. The regional framework has been published and also been endorsed by all the countries in these regions. And for the framework, what has been done is we call it through the lens of 2030, is mainly to use the principle of backcasting to address how to address the NTB study. So we can see here, if we look at the end of 2030, what we hope to happen in 2030 is a quite low instance. So when you look back, what is needed, in fact, is a new tool introduced, and so that we can approach in the pre-elimination level. But the reality is that there's a wide range of instances of tuberculosis in these regions, in different countries, in terms of number and also instances shown by this slide. So obviously that different countries would need different activities to deal with tuberculosis. So again, through the lens of 2030s, in order to achieve that, you will see that those countries with high burden of tuberculosis then need to make a lot of efforts to reduce, to make the job happen. But even those countries with a low incidence currently, they also need to maintain activities so that we can really suppress the incidence of tuberculosis at a very low level. So there are a lot of things to be done. And the current situation, you can see that TB, the estimated notification, and then those being treated. This is a drug-resistant tuberculosis. MDR-TB stand for resistance to isoniazid and rifampicin, the most important two drugs. You can see here this estimated number, lab confirmed, enroll on treatment, successfully treated. And among TB HIV, you can also say there are a lot of things to do, need to be done. So obviously we need investment. Without investment, it's very difficult. So the modeling shows that the baseline will be like this. We want to make it happen, we need to introduce the gene expert, that is a rapid diagnosis using PCR that can detect tuberculosis as well as resistance to rifampicin. Active case finding, go for screening, because the prevalence survey showed that a high proportion of smear positive, cultural positive TB patients, they remain in the community without diagnosis, and then preventive therapy. So everything come together, you might be able to see something may happen to achieve the target of the NTB strategy. So we discussed what are the key challenges on the way forward. So we divide that into different areas. TB, challenge in TB care, challenges within health, but beyond TB, and then also issues, social issues beyond health. Finally, would be the overarching challenges, including the financing, coordination, accountability, and planning in emergency. So we believe that the issues, in fact, is interconnectedness of the cause and effect. So linking with the SDG, you can see that urbanization, migration, climate change, weak and inadequate socio-economical policies, lack of social protections, all come together with a lot of challenges here, and that would promote transmission and also impair the host immune response. That will promote from the transition from exposure to infection to active disease, and people may die. So all of these need to be addressed in order to really tackle the issue of tuberculosis. So the response framework that been put forward in this document, the principle will be the social justice, ethic, and also human rights. That will need to be the principle of the whole response framework. The approaches will be country focused. As I show you that the burden of TB is different widely between countries in this region. And also we need a multi-sectoral approach. This cannot be done only by those who focus on tuberculosis, and also cannot be achieved by those who really working in the healthcare facility, the public health. We need to go beyond health to have a multi-sectoral approach in order to really get the job done. And then different action domains need to be also being addressed one by one. And then operational modality will be systems approach. The whole of the government, the whole of the society will need to come together to strengthen the service delivery. And then information obviously is important to track what happened in this field in terms of case finding, detection, preventive therapy, and reduction of incidence and mortality. And then strategic communications and change, also the management, and then innovations including diagnosis, vaccination, treatments need to have a rapid uptake. And in fact, that happens quite quickly in the in tuberculosis prevention and care. So despite the challenge of COVID-19, I think it's still time to end TB. With this, I thank you for your attention.
Thank you very much for the many instructive and inspiring speech. Professor Zhang not only told us about the challenge of the tuberculosis prevention and control resulting from the impact of COVID-19, he also indicates the opportunities for strengthening the tuberculosis control prevention in the future after the pandemic, COVID pandemic. So now we will move to the general discussion. May I invite the TMU College of Public Health Dean, Professor Chen Yifa, to join me to chair the general discussion.
Okay, yeah, we're so excited to have 4 speakers talking about the infectious disease under the COVID-19 pandemic. Yeah, and then we learned a lot of experiences, including those from Thailand and from Taiwan, and also not only for COVID, but also for TB prevention and intervention. Well, so I guess you would have a lot of questions, and then all of our speakers are actually here, the last section. So we'll emphasize our questions on the
last section first. But if you have more questions in the previous section, we'll be able to discuss that later. Okay?
Hello. My question is to Professor Zhang regarding the TB program. As the world-class expert in TB, how do you wonder that if we have been able to invest so swiftly and quickly in the last few decades, like the way we responded to COVID, how do you feel that, and wouldn't TB would have been largely reduced, the burden of TB, if we could also mobilize so much resources like the way we reacted to COVID? And because we know that TB, in terms of diagnostic, vaccine, treatments are very, very underinvested. But on the other hand, we probably can take advantage of all these new tools developed for COVID, and TB hopefully can take advantage of this new platform of vaccination. How do you see, in terms of more long-term, that our responses to the COVID would be in some way beneficial to the TB and HIV pandemic, which almost like being forgotten now?
Yeah, thank you for your questions. I think this is an excellent one. It's obviously that a lot of things we can learn COVID, and I agree with you that with the lot of investment, it's possible to make it happen. Up to now, the tuberculosis is the most successful pathogen in the world. The tuberculosis has been managed to co-evolve with human beings for many, many decades. Not only decades, but thousands of years, you know. And so they know how to manage our system, immune system. So when you're infected, you don't feel it. Even when you develop disease, you don't really think that you are sick. So that's the reason that they got opportunity to continue to spread. But now you can see that, you know, there are publications recently, also my colleagues, the Gaimax, that what they did in Vietnam is that they know when people develop disease, they are going to spread. But we were never able to really to quickly detect those cases if we wait for them to come up to the healthcare facility. So what they did is that they go to the communities and have sputum examination of all of them, as long as they can produce sputum. And by doing so, in 3 years, you see a big reduction of the incidence and prevalence. So that would remove infection, new infection. And they have not yet done preventive therapy. So if it can expand contact tracing, also provide preventive therapy, the incidence can come down quite quickly. So that is just one example. That we got investments, we can really, you know, detect those cases early, quickly, ensure that they have been treated successfully. The dream that we have is that if we can reduce the duration of treatment to 1 week, then it will be quite, you know, much easier to really to control this disease. But you see that the development of medicines for TB are so slow, so slow. So we still need several months to treat them, right? Vaccination, we still depend on BCG. BCG was developed in 1921, long time ago. And you see that I just recently read 3 books about the development of COVID-19. One is about AZ, one is about BNT, and then Pfizer's. In 1 year, they come up with the vaccinations for COVID. So, but for TB are so slow, right? So new innovations, yes. We recently introduced a new machine that can detect drug-resistant tuberculosis. That has also been developed in past 10 years, but I think we need more for like a whole genome sequencing that can quickly, you know, develop, detect all the resistance, and then we can really use precision medicine to decide who need what medicine. So I think there are so many things to be done, and then we also need to learn. You see that global TB report once per year. COVID, you see the dashboard everywhere. Johns Hopkins, WHO, action, data for action, everywhere. But no one really, you know, very few people pay attention to TB. So we also need that kind of data, quickly come up with data, and that need to result in action. In fact, tuberculosis is also, you know, you can see the clustering. You can see, you know, if you put on the map, you can see the cluster of cases. And then you can do action, you know. You can also something like to like what has been done for polio. When you see cases, then you quickly go for actions and to trace those contacts, So that is possible. So what is needed is really commitment. So that's what reason why we put in the framework, not only for TB but also challenges within health beyond TB and then beyond health that need to come together. Thank you.
May I continue this topic? Well, so because during the COVID-19, a lot of technology or we say digital device has been involved in the responses to the COVID pandemic. So in your previous talk, you talk about in terms of the training or some health educations can be performed through the digital platform. So, well, I was thinking, well, if it's possible that in the future applications, a lot of more kind of digital device technology can be involved in the reaction to the TB prevention and the treatment. What do you think?
Yes, this health education is also important. Training of healthcare workers obviously is very important. I began to do the international training on the diagnosis and management of drug-resistant tuberculosis in 2007. So since 2007, I've been doing that in different parts of the world for global international training courses as well as national courses. Up to 2019, every year we have a course in Bangkok. 2020 stopped because of the pandemic. And then we decided to transform that into a virtual platform through Zoom. And then we also adapt the training material into this kind of the online training. And so we developed 24 education units. The people need to take 4 units before we have a live session, and then 4 units before another live session. So that kind of experience, I think, is quite interesting, also quite new, and I learned a lot from that. And we developed a new way of interaction with participants. So I think that could be a useful platform, not only for treatment, but also the new knowledges and new tools and training could be done. And also treatment support provided to patients are important. So many things could be. In fact, we got used to this online training, online meetings, and that will be useful, I think, for education, not only for healthcare workers, but also for patients, for community, for the society. Thank you.
The tuberculosis issue, we do observe a remarkable reduction of respiratory tract infectious disease, including common cold as well as flu, and even the enterovirus contact-mediated transmission, remarkable reduction. It happened to Taiwan. Do you think that in case of tuberculosis control, it will also happen to Taiwan in contrary to resources limited country as you present? We will have reduction in tuberculosis incidence.
Yeah, thank you. I think so. I think that, Taiwan CDC says pay attention to also reduction of notification of TB in 2020 and 2021. And we see that the trend is going down in past 15 years. So we can track the proportion decrease year by year. And 2020, 2021, there's an increased proportion of reduction. But to what extent that was due to delayed diagnosis, delayed reporting? Not sure. I think part of that perhaps also come from everyone almost unmasked. So even you have delayed diagnosis, you also reduce transmission. So in fact, I think TB has been successful because of Homo sapiens stay together. Without this kind of habit, you stay together, tuberculosis would not be able to be so successful. So when everybody unmasked, the pathogen for respiratory disease would also suffer. So I think that tuberculosis perhaps also suffer from this kind of change of behavior of human being. But I don't know for how long we will continue to put this kind of mask. So that could be one of the study. In fact, I think that perhaps we can propose that for some countries without resource. The study that I mentioned for Vietnam is very expensive. Gene expert, sputum exam for all. One test in Taiwan, 1,000 US NT dollar, and globally is 20 US dollar. So you think about $20 per test for the whole population is so difficult. But if everybody unmasked, that even if you develop disease, you would reduce transmission to others simply because you put on mask. That's my hypothesis. So I think that perhaps we should look for opportunity to test this hypothesis. Thank you.
Thank you. And I have a question for the Dr. Wu as well as for Professor Chai. Yeah, because you talk about the resilience, and of course, resilience in the health care field is also very important. And I have a strange idea, which was after interaction with my hospital superintendent. He said that in case of health professionals shortage, can we ask the health professionals infected with COVID-19, but just the mild symptoms, to take care of the victim of COVID-19? That's resilience.
I'm not sure if I can answer such a question in this way. But I think resilience is a concept that they are quickly responding and then back to the general situations. So that also, of course, covers different, for example, currently under the regulations, everybody were quite similar. If we really want to introduce that kind of approaches, there should be a special regulations for the healthcare professionals in the special settings. But law related to the concept of populations. So I think the first important thing is that if we allow this kind of approaches, will there be any epidemiological problems after? If in the end it shows that it's much more either cost effectiveness or either beneficials better than the harmful effects might be, then there could be a possibility for that. I guess the issues in low and public infectious disease will be the balance between the technical approaches and also the concern of the human feelings and so on. So responding to these questions, I guess this should be the concerns from both sides. And after careful evaluation, there could be, but legally speaking and epidemiologically speaking, there should be more evaluations on that, I guess.
Okay, may I ask Dr. Wu online? Do you think it's possible that Central Epidemic Command Center someday in the future? 他在线上吗? Oh, no. Okay, that's fine. I just wonder, Central Epidemic Command Center will announce this policy in case we have collapse of health professionals. Yeah, because they made the policy that HIV-infected person can donate organ to the HIV-infected person. Okay, so that's my extension of the idea. May I have the question again to Professor Chai regarding the, that most of the developed countries do have high scores in IHR capacity, both in self-assessment and the JEE. However, during the COVID pandemic, those countries are mostly seriously affected. What makes it happen?
Thank you for that important question. I guess that's the thing that we really want to answer. So that's the reason why we conduct different studies trying to answer that questions. What happens if they are being as well prepared? Then why that happens? And especially before COVID-19, the study of us shows that the correlations between infectious disease outcome is positively correlated with the scores, which means that they perform well. So the scores are really representing their capacity. But that's for already known disease. already known diseases. So COVID-19 shows us the unknown diseases. I guess that's the lack of conscious of the unknown diseases. And also there are other social concerns, not only the conscious about the diseases make that happen. Especially, usually people will ask, or around the world, people are wondering why those kind of policies introduced in Taiwan did not they actually raise the severe population concern and even becomes a peril, whatever. Then my explanations previously provide the policy memo to Brookings institutions who want to introduce the possible policies for democratic countries to reconsider if there is any further possibility for using technology in public health in the democratic countries. So my explanation and my observation is that actually Taiwan society goes through a long time discussions regarding the balance between both. So that could be a possibility that the values in Taiwan regarding the balance between infectious disease control with the power of the governments and the value in the society is ever been discussed ever. And that's the reason why this time we see this kind of comparatively successful outcomes. But maybe for those countries, because they are already, they did not have the opportunity like us for SARS. So they don't really take too much time debating again, where is the balance? So that would be one of the possible explanations here. Thank you.
Question is forwarded to Professor Mastros. I love your term, either the disinformation or misinformation, the so-called infodemic. Okay, in Taiwan we have many misinformation or disinformation coming from outside our country instead of within the country. Do you have similar problem in your country? Thank you.
Thank you very much. I think under the technology disruption era, every country are facing with the same problem. Like in Thailand, although many experts and public health scholars try to explain that wearing face mask is very important. But because of the information from other countries mentioned like, no, it's not unnecessarily, it cannot prevent anything, something like that. And also about the efficacy of vaccine as well, and in particular those like those adverse events that compromise many Thai citizens' compliance to the public health measure very much. I would say up to now, the environment become a really important factor to public health. Public health progress and also operation. I think it might be the way that we have to concern about this. Thank you very much.
Thank you.
Well, back to Director Chan's previous idea about resilience. I think that's really very interesting because we all know that in the facing of the Omicron, hospitals and healthcare personnel are actually key in this battle. Yeah, so, well, however, Dr. Wu is not here from Taiwan CDC. Well, anyway, I have a questions for Dr. Mathoros from Mahido. Okay, so yeah, thank you for sharing your very valuable experiences from Thailand. And we see that, well, in Thailand, actually, there are a couple of webs. If I recall correctly, 5 webs, right? And especially the last 2 are actually more serious. And yeah, I think it's good that you propose 3 C's approach in the face of the COVID-19. So, well, my question is that, well, what would you think the most difficult challenges in Taiwan to face, in Thailand to face the COVID-19 pandemic? And in addition to that, in terms of the health behavior, like wearing masks or social distancing, yeah. Well, a lot of countries, in different, people in different countries may react that kind of health behavior differently, especially in some Western countries, maybe a lot of mask things. So I would like to know, well, how would the people's health behavior in Thailand in coping with the COVID? Yeah, at this moment. Thank you.
Please turn on your microphone. Dr. Mastros, please turn on your microphone.
ไม่พี่คงต้องคนอิ๋วส่งคราวนี้เนี่ยตัวเอกสารที่พี่ต้องลงนามอยากให้อิ๋วช่วยรีมาร์คมาให้นิดนึง
Hi, so Professor Matheros, did you hear my questions previously?
No, I cannot hear the voice at all. Apology that I'm not pretty sure what's happening to my audio, but I cannot hear your question. Could you please repeat it again? Thank you very much. Can you hear my voice? Can you hear my voice? Hello?
Okay, so you said okay now. Can you, are you able to hear me now?
Yes.
Okay, all right. So, well, let me rephrase my questions. Well, I said that, well, in Thailand, we know that there will be 5 waves of the outbreak, right? Especially the last 2 will be more serious. So my question is that what would be the most difficult challenges in Thailand to face with the COVID-19 pandemic? And in addition to that, yeah, it's good that you propose the 3 C's approaches. And I'm wondering in terms of the health behavior, like mask wearing, like social distancing, I'm not sure if people in Thailand will be able to adapt those behavior or accept those behavior well, because we can see that in some other, especially Western countries, people may have some anti-mask or some of the health behaviors, things like that. Well, so what would be the conditions in Thailand?
Thank you very much. I will start from the easier question first. Okay, for the public health measure or social measure that you just mentioned, like those face mask wearing and also social distancing, I would say a majority of citizens can follow that step quite well. However, as you know, public health is not that easy. They still have some group of people that not rely on the condition much, do not comply with the public health measure much. But in majority, I think the major population, they follow this step. If you come to Bangkok recently, you may find so many people who walk in the public area, they were wearing the face mask properly. This is the first thing. And if you're talking about the challenge of the COVID-19 prevention and control, I think a very important point, if you're looking at the COVID-19 pandemic in the second wave and third wave, it just come from, I think maybe the people and also the public health, they become fatigued. And after they feel emotional fatigue, they cannot comply that much. This is like a main challenge of us. And the second challenge of us, I would say, because we have the geography limitation, challenge that I just mentioned earlier, we have so many high-risk population, high-risk immigrant come across the country. And that pushed us into the situation that we cannot control the problem quite well across in the border of Thailand. According to our current situation, we found that many people who passed the ground crossing to Thailand, about 50% of them or 70 to 60% of them are infected with COVID-19, and that but we cannot detect the 100% of them. This is our major challenge up to now. And the previous time we still have some challenge on vaccine hesitancy, but right now it seems like everyone get a very good information and they accepted the number of vaccine uptake increasing time by time. And up to now, based on my currently checking on the information, our number of COVID-19 vaccinated person is already meet the target. It is already met the target. This is all my response. Thank you very much. Apologies that I couldn't hear your voice earlier. I don't know what happened, but now it's like your voice again.
Thank you. Well, there's one more question there. All right, please.
For the question, I want to respond to. What is this? Be the yourself and mask can protect other people. So yes, mask can stop not only flu and TB, but also the COVID-19 is due to it can stop the aerosol with the virus. Yes, your hypothesis has been approved in the field of occupational and environmental health. So yes, you're right. Your hypothesis is right. Okay. My question is for Professor Chai. You mentioned about the health and freedom. Yes, I agree with you. Both are human rights. So my question is, can we really restrict a person who might be a confirmed case or who have contact with a COVID-19 case based on imprecise detection technology or imprecise contact tracing? And what's the base of the law? Or even we ask them to confess everything, even the privacy? That's my question. Thank you.
I think this is a really big question, and then actually, the policy introduced by CDC is still under the debates and the questions. For example, what you mentioned about electronic quarantine and so on, the contact tracing and so on. So from the legal perspective, yes, they have a really broad legal basis, not really a perfect one, actually, but they do. So that one comes from the CDC regulations after SARS. So at that time, they have a really broad kind of authorities provided for CDC and also for the special act to COVID-19. But doesn't mean that they COVID-19. But doesn't mean that they, because of the purpose of protecting the public health, then everything can be done. So now there is also a debate regarding that too, and also the 监察院 there's also pointing out that CDC have to rethink about those policies, especially when those kind of policy might violating the human rights. currently. So I would say that those kind of policy we are facing now will actually be challenges after. Similarly, like USA, some of the policies was introduced in the very beginnings, but then in the court it will be felt if the balance was thin is not there. So all the policies here we observe here, yes, they show the effectiveness, and it brought a lot of debate problems. So I'm not, I don't think all the approaches we are taking now will be sustained. I don't think so. But some of them might have some basis, but some will maybe can be improved in the futures also. So that's my easy answer. Thank you.
Yeah, I think time is up now. Well, so I would like to thank you all for participating today's forum. And it should be a long day, but feels so short, right? Well, so adapt to COVID-19 pandemic is a changing process. And we continue to learn lessons from once in the century pandemic outbreak. Well, so we often say that things that change has been changed forever. So in this post-pandemic era, important health issues, including like chronic and infectious disease and health behavior should be reconsidered and resources relocated. So with the experiences sharing today, I believe that we'll be able to plan well our next important step. So again, I would like to thank for all the speakers today who share their valuable experiences with us, and for all the participants who exchange their thoughts and discuss over here, and also all of our staff who devoted themselves for actually several weeks ago, since several weeks ago to try to make this forum success. Yeah, thank you all for all your contribution that makes today's forum a very good discussion, display, and success. So have a nice weekend, and actually happy Mother's Day coming Sunday. And of course, during this huge outbreak in Taiwan, please take care of yourself and stay safe and sound. Thank you so much. Thank you. Bye-bye.
Just a reminder for in-person attendees, when you do sign out, or make sure to sign out and write afternoon next to your signature so that we know that you were here for both